Welcome, everybody, to a very special event brought to you by Grassroots Health and IPAC EDU. We will be discussing vitamin D dosing policy and updates with an expert panel discussion. And thank you, everybody, for joining us today. We are bringing together the world's leading researchers and clinicians to examine the current state of vitamin D science in comparison to existing vitamin D guidelines and its implications for public health and policy. Our objective is to explore key vitamin D policy issues alongside the current evidence suggesting necessary and immediate changes to vitamin D guidelines and policy. This is a 2.5 hour event. We may go over, as a lot of us love to talk about vitamin D. I'll be starting with our opening and introduction, followed by individual speaker presentations, and I will introduce each of our speakers just prior to their presentation. We'll follow those up with key takeaways and action items, and then our open Q&A with the audience. So just very briefly, for those of you who are new to Grassroots Health was started in 2007 by Carol Baggerly. We are a 501c3 nonprofit organization. And Carol began Grassroots Health along with 40 senior vitamin D researchers based on a consensus and a call to action that really called out that vitamin D deficiency and insufficiency was incredibly common and contributes to increased risk of many diseases beyond bone health. Our vision is to eliminate the worldwide vitamin D deficiency. Everything we do at Grassroots Health is really keyed into that vision, and our tagline is moving research into practice. We work with these amazing researchers who will be speaking today, and we're really here to implement that research into practice. There is more than enough research now to make change happen. And I am incredibly honored to work alongside the world's top vitamin D scientists and experts, many of whom have spent decades researching vitamin D and incorporating their findings into practice. Each of these scientists brings an incredible amount of expertise and credibility to the work of Grassroots Health and to this presentation today. And I want to extend my deepest thanks to each and every one of you. So with that, I would like to turn the floor over to Dr. James Lyons-Wheeler.
Okay, so I'm James Lyons-Weiler. I'm the president and CEO of IPAC, the Institute for Pure and Applied Knowledge, and I founded IPAC EDU. We had something like 2,500 to 3,000 people take courses as a result of COVID so they could learn immunology and statistics and keep up with the bad guys as they were lying with statistics and lying about public health policy. So, vitamin D, problems with vitamin D dosing actually first came to my attention when I saw a friend of mine, a colleague of mine, Keith Baggerly, give a presentation about it online. I knew Keith from many, many years ago when I worked with the Early Detection Research Network in cancer. And I was really pleased to see that he was advancing the knowledge of the problem with vitamin D mistakes. So that's what my talk is going to be about today. I'm just going to share some slides. I probably won't even take up the whole 5 minutes. I'm not going to go into great detail, but you can bet that you can find more detail about this at Popular Rationalism on Substack. I've written one article. I'm going to write another article about it. And of course, you can find a lot of articles there. We're transitioning everything at IPAC EDU over to IPAC EDU online. So it's a social media platform that we're creating to bring about 4,000 or 5,000 people together to do great work. But let's get underway here and talk about one of the mistakes, or many mistakes. We're going to hear from many of the speakers here about all the mistakes that have been made over the years, but in vitamin D dosing. So everybody who's speaking today will probably go over this and clarify it, but the RDA, the recommended daily allowance right now, is somewhere around 600, 800 international units a day. And we want to distinguish that from the tolerable upper limit intake level, or the upper level. And part of the mistake that was made, and I'm going to make it very, very painfully clear about how and why they made the mistake. It was a inferential error. It wasn't a mathematical error or a statistical error. It was just looking at statistics wrong and doing analysis wrong. And this is documented. It is not controversial. This mistake is absolutely published in the peer-reviewed literature. The Institutes of Medicine, 100%. Now the National Academy of Sciences, and have validated it. But what they did was they said that the lower 95% prediction interval for the upper limit, not the RDA, but the upper limit of exposure was determined using something that allowed that level to be too low. And the way that it was too low is because that they handled individual study averages as if they cover the entire distribution of diversity among individuals. And it's really obvious when you think about it. If you know about statistics, it's called regression to the mean. The idea that 97.5% of individuals, might actually be above a certain level based on inferences, based on what the averages are telling us, is patently false. You can't get there from here, to quote my friends from New England. Um, and so I came up with this cartoon. It's, if you want a copy of it, go to popularrationalism.substack.com. So let's say that my job as I'm an engineer and I'm going to make bridges in my town, and I know that there's diversity among the trucks. And so I want to be sure that the trucks aren't too high, and an acceptable risk so that we can have to reroute a certain amount of traffic is 2.5% of trucks will have to be rerouted, right? And so because of the variation among the trucks, what I do is I go to the literature and I look at the average of different kinds of trucks, maybe different categories of shipping needs or companies or produce or something. And I take those averages and I go, well, listen, on average, the average of all these trucks are lower than this. And so I can actually have the bridge at a certain height, or maybe they're higher than this. And so, I can have my bridges a certain height. And so if I get that wrong and I don't look at all the diversity of trucks that are out there, then the math that you do when you look at the average of distributions rather than the average of all individuals in a population is you're going to have a lot of trucks that are hitting the bridge, right, that you don't anticipate. And so you're going to have to reroute a lot more traffic. And that's what's happening here. So I won't go through it in great detail, like I said, but there's more variation among individuals in the population than there is variation among averages among studies. That's the problem. So they really made a silly mistake, and it's not controversial. Another example of how to understand what they said about that upper limit is by taking the average. If I said to you that most classrooms averaged above a passing grade, it's certainly not the same thing that of saying that 97.5% of students passed. Those are two different inferences. And so the Institutes of Medicine, they try to release some new DRI limits, recommended intake. Catherine Ross, Catherine Ross shared that, and they still are very, very, very low compared to what the data would actually support. Here's one of the studies that got it started. Some Canadian scientists looked at the statistical error and said, hey, we published this. This is in the journal Nutrients in 2014. Now it's 2026, so it's been a while. And because of that statistical error that I told you about, then it was confirmed. If you look at independent data, and this is some people associated with grassroots health data, they analyzed it, Heaney et al. They said, hey, look, it's actually you have to have higher intake than we thought. And Carol is on there and so on. So, this is a problem that's very well known to this particular group. Our job today is to make sure that the Institutes of Medicine, I'm sorry, I misspoke, that HHS understands that there are consequences for them. They're continuing to distribute the wrong information. There's never been a revision of the RDA. There's never been a revision of the upper limit based on the fact, even though we know that the problem was there, the data are published and they can now determine what a more reasonable limit would be. Um, and it's been the frustration of everybody that's going to be presenting today for years and years that no one seems to be able to move the needle. And Robert F. Kennedy Jr. is the secretary of HHS, and I spoke with him about this problem, and I wrote up something for him, which he ended up distributing across HHS. Um, and hopefully there'll be some action. But we're not seeing that action yet, and so we got to keep the heat on. We want to bring it to the public and say there's a problem here that the science as it stands is not being translated into policy. And really, it basically boils down to correcting the website here and there across HHS um, for the most part and other publications. But there are other consequences that we're going to recap at the end, like maybe we need to update medical education, and maybe we need to study the consequences of you enroll somebody in a clinical trial for research and they have low vitamin D. I mean, why would you do that? You want to increase the health of the population, then you should take a look at what's happening when, doctors are practicing ethical medicine, let's call it that. So there have been debates, there have been positions on it. There are health consequences for pregnancy and maternal. We're going to get into all of this, I'm sure. People on the call are much more expert than I am. Children and adolescent deficiencies, very important. Geriatric population, very important. But let's just say that there's a problem because while the knowledge base has shifted, the policy hasn't changed. And we know the health consequences, but we need to talk about it. So I'm happy to turn it back over to you, Jen, and stop sharing. And we're going to move right on to the next one.
Thank you, James. Yeah, so Dr. Michael Hollick will be speaking next. Uh, Dr. Michael Hollick is a pioneering physician scientist and one of the world's leading experts on vitamin D, whose decades of research have helped shape modern understanding of vitamin D metabolism, deficiency, and its impact on human health. As professor of medicine, pharmacology, physiology, biophysics, and molecular medicine at Boston University School of Medicine, Dr. Hollick has authored more than 900 scientific publications and has been actively involved in the development and discussion of vitamin D guidelines and public health recommendations over the course of his career. Welcome, Dr. Hollick.
Thank you so much for that kind introduction, Jen. So I'm going to give you a very broad overview of the 2010 IOM guidelines, the 2011 and 2024 Endocrine Society guidelines, history and shortcomings, and a 2026 perspective. People worry about conflicts of interest, and so I do consult and speak, and I also get support from NIH. Now, you might think I'm an idiot because what am I going to tell you about vitamin D that you don't already know about from the Institute of Medicine report and the 2024 guidelines? And it turns out that the Institute of Medicine in 2010, they realized something, that the 200 units a day was inadequate, and they recommended 600 units a day. So the RDA was increased threefold. They also realized that 2,000 units a day isn't toxic, and they've recommended the upper limit can now be 4,000 units a day. That's amazing when you think about this. I'm constantly asked, what do I think about this? And I have only one word for it. Wow, right? Because no nutrient has been increased by that amount in such a short period of time. The question is, did they get it right? In 2011, the Endocrine Society Practice Guidelines, I was fortunate to chair that committee. All the members are experts in the field of vitamin D. And it turns out that the guidelines were specifically for prevention treatment of vitamin D deficiency. The IOM guidelines was not intended for physicians. It was recommended that professional associations should make those guidelines for patient care. And they used a population model, not a medical model. So the recommendation in 2011 from Endocrine Society, 400 to 1,000 unit for neonates, 600 to 1,000 for children, and adults, 1,500 to 2,000 units a day. And if you're obese, 2 to 3 times more. Safe upper limit based on the literature, 2,000 units for infants, 4,000 units for children, 10,000 units for teenagers and adults. 2024 guidelines, you need to understand that those guidelines were not for patient care. They were guidelines for those that were vitamin D sufficient and could take additional vitamin D for having other health benefits. But a priori decision that they made, they said that generally the population is healthy, and therefore the RDA should be the IOM recommendations, which is 600 units a day for most children and adults. Therefore, the 2024 guidelines assume a healthy population that's vitamin D sufficient. And what do they recommend? 1 to 18 years, 600 units a day. 18 to 70, 600 units a day. 75 and plus 900 units a day. Obesity, they don't recommend anything. And they don't recommend anything for the first year of life. Again, 2011 guidelines for infants and for children and for adults and obesity all were recommended. Is vitamin D deficiency a health issue? It's estimated 40% of the world's population is deficient, 60% insufficient. Here, a National Health Survey data from U.S. population showed less than 50% of the U.S. population is vitamin D sufficient, and some in the ages of 10 up to 30 no more than about 30% are sufficient. Recommendation 12 from the 2024 guidelines. Healthy adults, we suggest against routine screening for vitamin D status. So why should you care? Well, it turns out that vitamin D is important for pregnancy, and we showed with Lisa Bodner many years ago, the higher the 25-hydroxy-D in pregnancy, lower is the risk for preeclampsia. A very nice study looking at gestational age and 25-hydroxy-D, 60% reduction in premature births if your blood level is greater than 40 nanograms per ml. Mom, thanks for taking your vitamin D. Recommendation 8 from the 2024 guidelines. We suggest empiric vitamin D supplementation during pregnancy, given the potential lower risk of preeclampsia, intrauterine mortality, preterm birth, small for gestational age. That's fantastic. And they recommend 2,500 units of vitamin D a day. However, again, go back to the a priori decision. The panel said healthy population. And so even pregnant women, they recommend 600 units of vitamin D a day. 2024 guidelines, pregnancy, 600 units a day, even though they appreciated from the literature that a higher dose will markedly improve birth outcomes. Obesity is associated with vitamin D deficiency. The higher your BMI, lower is your vitamin D status. And so a study was done by Ikwaru many years ago. And what he did was he looked at serum concentrations of 25-hydroxy-D and how much vitamin D they were taking, and to see what would happen if you're normal weight, underweight, and obese. And he showed very nicely to get to the same level as a normal person, you would need to take 2.5 times more vitamin D to satisfy an obese person's requirement. They need 2 to 3 times more. Recommendation 14 from 2024 guidelines, they say adults, we suggest against routine screening for 25-hydroxy vitamin D, especially with obesity. The guidelines recommend obesity. They don't have any recommendation for obesity. IOM had used this study as a way of defining vitamin D status for bone health. And the Endocrine Society looked at the study as well and talk about another error in calculation. This is 675 German adults, ages 20 to 90 years of age, and bone biopsies and blood was taken. And the authors concluded to see no evidence of vitamin D deficiency bone disease, you needed to be greater than 30 nanograms per ml. And in fact, the Institute of Medicine said, wait a second, not really, because if you take the number between 21 and 29 for those that have osteomalacia, over all that are deficient or insufficient, only about 1% have bone disease. So that's no consequence, right? But the problem is they made an error, right? Typically, when you're going to do a analysis, you want to have this as your numerator and this is your denominator, 21 to 29. And if you do that, 22% of otherwise healthy German adults were found to be vitamin D deficient in the sense that they had osteomalacia, bone disease. None had greater than 30 nanograms per ml. And that's why the Endocrine Society in 2011 recommended 30 should be your minimum, 40 to 60 is preferred, especially because of the vagaries of the assays that were out there. Up to 100 is perfectly safe. Also, working with Bob Heaney many years ago, we showed 10,000 units of vitamin D a day to healthy adults is safe. And also a nice study again by Aquaro showed 4,000 to 5,000 units a day, blood level around 40, 20,000 units a day, about 60. In 22,000 observations, no toxicity. What about COVID? When COVID hit, because vitamin D does play a role in your immune system, I worked with Quest Diagnostics, looked at over 190,000 patient samples. And what did we find? We found that if you were vitamin D sufficient, 25-hydroxy D of at least 34 nanograms per ml, 54% likelihood of having COVID. We also look at our hospital and we're shocked to find if you walk in the hospital vitamin D sufficient, overall decreased odds of death was 67%. Overall odds of death ratio 82% if you were sufficient and you had normal weight. Recommendation 1 from the 2024 guidelines, they say that empiric supplementation for children can potentially help in reducing risk of respiratory tract infections. Right? And they said about 1,200 units a day, which is fantastic, except that they don't make any recommendations for children or adults to increase your vitamin D intake for anything. They just say 600 units a day. Vitamin D supplementation and diabetes, a paper came out, the D2D study originally said doesn't work. However, when you do and look at the data more carefully, and you look at those that had a blood level of at least 50 nanograms per ml compared to 20 to 29 nanograms per ml, they had a 76% with a 3-year absolute risk reduction from pre-diabetes to diabetes, which is truly remarkable. CDC estimates that more than about 50% of the US population has either pre-diabetes or diabetes. Recommendation 10 from, again, the 24 guidelines. Adults with high risk of prediabetes, in addition to lifestyle modification, they recognize 3,500 units a day can help. But again, what do they say? They assume that it's a healthy population, and they make no recommendations for adults that are obese or have prediabetes. Also, vitamin D supplementation and mortality. Here, a study showed 25% reduced risk. Cedric Garland showed very nicely, the higher your 25-hydroxy D, lower is your risk for mortality. What is recommendation 6 from the 24 guidelines? If you're age 75 and older, they automatically now say, don't take just 600, but 900 units of vitamin D a day, because that is going to help your survival rate. Your survival is based on everything that you've done as a child, young adult, middle-aged, and older adult. Not all of a sudden taking some vitamin D is going to make a difference for your mortality. Right? They recommend 75 plus and over at 900 units a day. Age-adjusted studies, again, look at this. This is Garland's data, 40 to 50 nanograms per ml, maximum benefit. You would have to take 4,000 to 5,000 units a day to achieve that level. And a study done many years ago by Luxwalda showed that these hunter-gatherers have blood levels of 40 to 50 nanograms per ml. And they would need to take, like I said, you would 4,000 to 5,000 units a day. Vitamin D deficiency is a disease of neglect. Don't think about a normal level, but a healthy level, right? How much vitamin D do you need? We know, based on studies we did with Bob Heaney, you need 100 units will raise your blood level by about 0.6 to 1 nanogram per ml. If you're not taking a supplement, your levels are in this range. So you think you can get it from your diet. There's essentially no vitamin D in your diet. You cannot get it from your diet. Right? We did a study in healthy adults in Boston at the end of the winter, 1,000 units a day. Essentially no one was vitamin D sufficient. I recommend minimum 2,000 units for adults, children, 1,000 units a day. Again, looking at the Aquaro study, 5,000 units a day for a normal weight person, 50 nanograms per ml. 10,000 units a day gets up to about 60 nanograms per ml. And if you're obese, you need 2 to 3 times more, right? I was asked to review the 2024 guidelines and pointed out there's a mountain of evidence linking vitamin D deficiency with increased risk for cancer, mortality, autoimmune diseases, etc., and showed that essentially all of these chronic illnesses can definitely be improved risk if your level is at least 30 and sometimes 40 to 60 nanograms per ml. Adequate vitamin D is critically important from birth until death. Vitamin D can help improve your health. And I thank you for your time.
Here comes the sun.
Thank you. That was fantastic as always. I love how animated you are, Dr. Hollick. All right, next up we have
All right,
Dr.
thank you.
Sunil Wimalawansa is director of the Cardiometabolic and Endocrine Institute and a former chief of endocrinology. A distinguished professor of medicine and human nutrition at Rutgers University, he is a respected clinician, researcher, and innovator, a philanthropist, and he has served as a board member and consultant to multiple scientific organizations. He holds multiple academic credentials and has authored hundreds of peer-reviewed scientific publications and several books spanning vitamin D physiology, osteoporosis, endocrine disorders, immune health, and chronic disease prevention. So I really appreciate that you are here with us today, Dr. Wimalawansa. I hope that your presentation goes well.
Thank you, Jen. And so the next 18 minutes or so, I'm going to discuss with you 15 key issues related to vitamin D, which would help you to understand better the presentation in this particular program, as well as any publication you're going to read related to vitamin D in the future. Firstly, vitamin D, the D3 is the one we preferred and should be used in supplementation, as well as it's the one which is generated on the skin. Calcidiol is a 25 hydroxy vitamin D, and 125 is the one produced in the skin as well as the peripheral target tissues. There are synthetic analogs based on both 25 and 1 alpha hydroxy vitamin Ds, which should not be used as a supplementation for vitamin D. So what is vitamin D? Firstly, it's a threshold nutrient, which is very important, and it has nothing to do with the pharmaceutical agent. They are very different. It has many physiological functions. It has a very shallow dose responses compared to pharmaceutical agent. And beyond that, being a threshold nutrient, beyond that, there's no added benefit by adding more nutrients. Secondly, it's also a network nutrient. But it means none of the micronutrients work on their own to benefit us. Micronutrients always work as the clusters of nutrients, what we call them as cofactors. In the case of vitamin D, you need magnesium, omega-3, K2, and in fact, there are several more other cofactors necessary to get the maximal benefits of vitamin D. So these cofactors are essential. So vitamin D deficiency can also occur in the presence of cofactor deficiencies. In addition, it also affects about 2,000 of our key vitamin D genes, which we have already mentioned in this presentation. Now, there are some of the outdated concepts has been mentioned. I'm going to mention a couple more here. When we expose the fair-skinned person, about 1/3 of the upper body to the midday sun, people can generate anything from 10 to 15,000 units of vitamin D in the body. So that's supposed to be the general safe generation of vitamin D. Yet governments, agencies, and even some scientific societies recommending 400 to 800 interaction units per day, as you have already heard. However, as Professor Hollick mentioned, 1,000 interaction units we recommend for infants. So this cannot be correct for recommending for adults. There's something wrong in the entire system. Similarly, targeting the 20 nanograms per milliliters based on the 1980s recommendation we already designed to prevention of rickets in children and osteomalacia in adults, but nothing whatsoever to do with the other benefits of vitamin D. Let's look at the very briefly the vitamin D physiology. Sun exposure generates in vitamin D. However, overexposure of UVB and also UVA can cause erythema and skin damage. Therefore, overexposure must be avoided. Nevertheless, excess sun exposure never causes overproduction of vitamin D or causes hypercalcemia. Because there are inherent mechanisms to prevent that happening in the skin. So, vitamin D functions. One of the key things in the recent days of importance is that 2/3 of the immune system function is driven by the vitamin D. Of course, it needs the other cofactors and other supplementary evidence as supporting factors to go in. So, add magnesium before the escalating of vitamin doses. When the vitamin D may not be working, maybe because of not insufficient vitamin D, magnesium is present in the system. So not necessarily the vitamin D deficiency itself. So vitamin D also has additional physiological and biological function, a lot more than what we discussed, including the DNA repair, energy generation, and a lot more. I'll discuss that in this particular slide very briefly. So as you see on the left side, it has got many other components and the different systems. And as you see, these slides will be appear on the video will available, which I'm not going to dwell. However, as you see on the right side, there's no downside with the vitamin D treatment. It's economical. There's no adverse effect on the recommended doses by this panel. And there's not a pharmacological agent. It is a nutrient. And there's a very safe wider margin. As I mentioned, cofactors are essential part of the vitamin D physiology and biological actions. So magnesium, don't forget the sufficiency is necessary for vitamin D action. In fact, some of the so-called vitamin D resistance syndrome could be due to these cofactor deficiencies. Similarly, vitamin D deficiency can also caused by proton pump inhibitors like a gastric acid inhibitors, inflammatory bowel diseases, fatty liver disease, chronic disease, kidney disease, etc. can also lead it to vitamin D deficiency. So don't underestimate those areas. The next one is the increased utilization of vitamin D in the presence of active diseases, especially any active infections or any indication for admission to ICUs. So as any race condition with the CRP is almost equivalent to increased requirement of vitamin D. In other words, in the utilization of vitamin D goes up. So demands also rises in autoimmune diseases, fractures, pregnancy, as well as in lactation. So the bottom line is that rapid depletion occurs without supplementation. So in these scenarios, if the patient admitted to the hospital even with the normal vitamin D, if the patient is acutely ill, if they don't supplement with vitamin D and magnesium, they can rapidly become insufficient or deficient within few days. And the hospital length of stay will increases, therefore the cost of healthcare will actually increases. So let's look at the blood levels again very briefly. So vitamin D status is measured only by the 24-hydroxy vitamin D level. 125-hydroxy level is a specific marker for renal diseases and should not be used for as vitamin D status measurements. So human physiological and nutritional threshold do not change between the healthy versus sick, as well as young versus old. So what is changing then? What is changing is vitamin D intake required to achieve and maintain the optimal body level. That changes between people, disease prevention and the management. Let's look at that a little bit more details. Why the same dose of vitamin D leads to different serum 25-hydroxy level in different people? Number of reasons. One, gastrointestinal absorption issues varies from person to person. It's not the same. Different individual had the different medication. Body mass indexes, which we discussed in previous presentation. Higher the fat mass, higher the sequestration, so as muscle mass. Similarly, differences in utilization in infection, as I just mentioned, pregnancy, physiology, lactation, as well as enhancement of metabolism, as well as some medication like anti-epileptic drug causing increased catabolism. Therefore, one cannot expect that same dose lead to have the same efficacy of vitamin D. Similarly, why can two people have the same serum level of but have two different biological outcomes? These are the questions a lot of people asking me. So I think it's the same question asking from you all. So that's what I put these two here. So one commonest and hidden thing is the genetic differences. We don't address this commonly because it's costly, somewhat costly to get the answers. These are the gene variants, particularly the gene pleomorphism, particularly the gene coding for the vitamin D binding protein, as well as the vitamin D receptor abnormalities. These are not that uncommon, by the way. And secondly, as I mentioned, it's very common to have a magnesium and other cofactor variabilities, the levels, as well as combination can lead to significant alteration of the sensitivity of the vitamin D to the body system. So that's one of the reasons some people are categorizing low versus high responders. Indirectly, it's not the responders. What we are having is these variables influencing the system. Consequently, that's why we need to have the wider normal range, like 40 to 100 nanograms mil, or in the lab point of view, they are even considering 30 to 100 nanograms mil as a very wide range in vitamin D. Here are some practical guidelines. In clinical trials, one should not rely on intakes of vitamin D. Instead, we need to change the culture to rely on the measurement of serum 25-hydroxy D measured 3 months into the clinical study. In other words, stable blood levels achieved. We have been preaching this for almost 10, 15 years, but no study has been done this yet. Similarly, this process can be accelerated by giving loading doses of vitamin D. In practice, we have been doing this in our clinic for at least 20 years, probably a lot longer than that. It has a significant benefit for the patient, advancing the benefits of vitamin D in this patient by several weeks, if not several months. So technically, this principle can be adapted to clinical practice and clinical trials, especially for high-risk patients. So, to maximize the benefits, clearly we need to individualize the treatment for patients. So no single dose applicable to all patients. So let's look at the blood levels of vitamin D. So simplify calculations, what you can use to approximately get into very close doses necessary for everybody without exception. So which is it based on the body weight or BMI Similarly, there's a calculation you can get through this publication based on the serum 25-hydroxy vitamin D level. Both give the equal, very approximate, but very good proximity correct amount of vitamin D necessary for an individual patient. As you see, the non-obese patient, about 70 to 90 international unit per kilogram body weight. As body weight increases, the amount necessary for kilogram body weight increases. Therefore, it automatically increases the amount needed to, the doses needed to that given patient. So this is what generally you need to remember in this situation. So what should be the minimum serum 25-hydroxyl calculation? This is a confusion going on for multiple publications. In my opinion, consideration levels 20, 30, 40 is a silo mentality, is misleading and is clearly unhelpful for patient care. What when maintaining the blood serum 25-hydroxy level between 50 and 80 nanograms per milliliters, as shown in the multiple recent studies, it encompasses 99.5% of the disorders. There is a 0.5% disorders. These are the rare disorders, vitamin D resistant disorders. This amount to about 0.55% disorder requiring much higher level of vitamin D serum level like 100 nanograms per milliliter, but it's a very, very small component of patient. Lastly, the various tissues and diseases respond to different serum tissue levels. This is another important factor we need to keep an eye on. So, on the background, also we need to remember that the free living human typically having a serum 25 level above 25 nanogram per milliliter, not 30. So adequate minimum level must be satisfy the functions of vitamin D to cover maximum amount of disorders. Why not? So this we recommend that in the range of 50 to 80 nanograms per milliliter. This range reduces the cardiovascular diseases, reduce the cancers, improve the pregnancy-related better outcomes, as well as the least amount of neurodegenerative disorders, include the Parkinson's and other neurovascular disorders. This does not vary by the age, race, ethnicity, skin color, or the latitude. So this is the human inherent genetic issue. So higher target needs, however, specific disease condition. So the rare disorder, as I said, like disorder like drug-resistant migraine, cluster headaches, drug-resistant psoriasis, some genetically acquired vitamin D resistant disorders, those are requiring much higher level. Nevertheless, these treatment for these disorders should not be treated by the general practitioner or even by the endocrinologist, but should be treated by the specialist supervision under experienced clinical centers, because these can develop into problem unless these patients are managed very carefully with the calcium-free diets and that kind of thing under specialist management. Here's the slide I generated a long time ago based on about more than 500 different published studies to summarizing different levels of vitamin D required to overcome the different system-based disorders. Again, I'm not going to go through this one, but as you see that this slide will be available in the video. But as you see that on the right side column, you can see that symptomatically, you can see that the amount of benefit occurring on these symptoms and the correlation between the amount of serum level and the symptomatic benefit of these disorders to achieve. So with the sun exposure plus supplements, knowing the level, and enjoying the better health with vitamin D, there's every reason to have vitamin D. It is simple, safe, essential, and as I shown and others shown that there's no downside. So to summarize last couple of slides, transform US healthcare, better care with a low cost. Let me show you a couple of slides on my thoughts. We have a fundamental failure in the United States and industrialized countries in general in the West. We have a high burden of chronic diseases across all stage groups, from infancy to death. This is because our pharmaceutical model-driven clinical care. We treat the symptoms and we forget the root cause analysis and treatment. This happened, as you know, some will remember that reflection report going back to 1908, I think. That changed the entire health system in the United States towards the negative. We need to change that. This is the opportunity of the new administrator to change it. So without changing that mindset, to changing back to the pharmaceutical model, to root cause driven model, we cannot change the healthcare system at all. So we need to go back to the root cause largely unaddressed. Micronutrient deficiencies, adverse toxic burden, food issues are partly being addressed right now. I'm very pleased to see that. The final slide. What's need to happen in addition? We need to integrate the nutrition and medical and nursing education into the curriculum, which is still not happening. Some of the medical curriculum still has only 2 hours of nutrition treatment. Vitamin D, perhaps 20 minutes for the entire education curriculum. Revise the vitamin D guideline using current evidence. Guidelines are 30 years outdated. Avoid RCT approaches in nutrition research. And Dr. Grant had mentioned we need to use the prospective studies instead of the RCTs for evaluation of all micronutrients, not necessarily vitamin D. So shift from the symptom-driven care to root cause medicine. And then finally, the most important, prioritize the primary care and chronic disease management instead of the specialist care and the hospitalized medicine. Thank you for your attention. Appreciate. Have a great day.
Thank you, Dr. Wimalawansa. That was excellent, and I hope you get some rest after this. All right, next up, we have Dr. William Grant, who is an internationally recognized researcher and the founder of Sunlight Nutrition and Health Research Center, where he has spent decades studying the relationships between vitamin D, sunlight exposure, nutrition, and chronic disease prevention. He is widely known for his extensive work in epidemiology and ecological health research, authoring hundreds of scientific publications examining the role of vitamin D and UVB exposure in reducing the risk of conditions such as cancer, cardiovascular disease, diabetes, autoimmune disorders, and respiratory infections. As a worldwide recognized expert writing about vitamin D and sunlight, Dr. Grant has been an important contributor to scientific discussions surrounding vitamin D guidelines and public health recommendations. So let's see if we can't get Dr. Grant up.
Okay, thanks for the introduction. So the advantages of observational studies include that they include large numbers of participants useful for minor diseases and accuracy for major diseases. Some studies can be conducted quickly using existing databases, such as the National Health and Nutrition Examination Surveys in Haines in the US and the UK Biobank. They generally include participants with large ranges of 25-OHD concentrations. Values for confounding factors are generally available at the same scale as the serum 25-OHD concentration data. Now, there are 2 types of ecological studies, temporal and geographical. Geographical were important in cancer to show that UVB and vitamin D reduce risk of cancer, as shown by the Garland brothers starting in 1974. The temporal ones show the seasonal variations. And here we have for the death rates from 1979 to 2004, showing a 27% increased death rate in winter compared to summer. And that's correlated primarily with with UVB, with vitamin D, which is in the lower, the blue the dashed line on the right, due to solar UVB. Now, there is primarily due to cardiovascular disease, but also infectious diseases. And you see two extra bumps, one in about February or March, one in about September, when they're more infectious diseases. It's interesting that wintertime 25-hydroxyvitamin D levels are about 70% as high as summer values. That's because of 25 OHD stored in muscle cells and released into the serum, as shown by our colleagues Mason and Ribchen in Australia. So the advantage of observation, okay, sorry. The prospective cohort studies are what's generally used for observational studies. In these, participants are enrolled, variables are measured, and health outcomes noted over a follow-up period of years. The results are analyzed according to serum 25 OHD concentration or vitamin D level at baseline with adjustments for various confounding factors. These are very useful, but subject to regression dilution due to changes in variable values over the time. And this was first demonstrated in 1999 by Clark et al. Michael Hollick just showed his response to the DeMay et al. New Endocrine Society guidelines for 2024. This is our similar reaction to those awful guidelines. And what we did was we took findings from observational studies for the top 10 causes of death in the U.S. and found that serum 25-hydroxyvitamin D concentrations above 30 nanograms per milliliter could significantly reduce the burden of disease for 8 of these top 10. And these 8 accounted for 90% of all deaths in 2021 and 2022, which was the COVID era. So these are the diseases I'm going to show the results for in the order we'll be presenting them. First, there's cardiovascular disease. This is a meta-analysis of 19 independent observational studies of CVD as known as of 2012. And what you see here is that for those with 25-hydroxyvitamin D less than 8 nanograms per milliliter, there was about a factor of 2 increased risk compared to sufficient 25-hydroxyvitamin D. And there was a deflection point around 25 or so nanograms per milliliter, which means above that point, you are not seeing any increased benefit of vitamin D supplementation. Here's another example for colorectal cancer. This is for a number of groups. This is for 17 cohorts, as originally reported by McCulloch et al. In 2019. What we did was we plotted the reduction for high versus low 25-hydroxyvitamin D versus median years to diagnosis. And what you see is that for men, you have a sharper, a steeper change with time they do for women. That's because men spend more time out of doors and have higher 25-hydroxyvitamin D concentration. But consistent with the results from Garland et al., there's about a 25% reduction for high versus low if you extrapolate to 0 follow-up time. Michael Hollick's already shown this for the virus associated with COVID. Here's an interesting study from Israel reported in 2022. For those with mild COVID, the mean 25-hydroxyvitamin D concentration is around 35 nanograms per milliliter. For moderate COVID, it was around 20. For severe, is around 12. For critical, is around 10. What's interesting is that this paper was retracted in 2025. on the basis that the inclusion of only patients for whom vitamin D determination had been performed before COVID-19 infection introduces bias. Well, this was really redacted because Big Pharma doesn't like publicity for natural compounds that are inexpensive and have strong health benefits. What we've seen is that if vitamin D were a patentable drug and could be sold for profit, it would be the most popular drug in the world. But since it isn't, it's sort of languishing. But vitamin D was blocked from for COVID, was blocked from mass media and even from the uh, 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 social media because Big Pharma and the system wanted to sell vaccinations and drugs for treating COVID. Here's for stroke. You see that for those with greater than 30 nanograms per milliliter versus less than 20 nanograms per milliliter, there's about a 60% reduction in risk of stroke for 1 year follow-up. By 10 years, there's no correlation. Again, this shows that the studies are all consistent if you account for follow-up period. Here's for COPD, chronic obstructive pulmonary disease. What we find here is the kink is around 18 nanograms per milliliter with a very steep rise for lower values. For dementia, we have over a factor of 2 increase at 5 years of follow-up for less than 20 versus greater than 30 nanograms per milliliter. And note that Alzheimer's disease accounts for about 70% of dementia. Now, Michael Hollick also mentioned this study from Tufts University. Again, what it shows is that there's a very significant reduction for those with higher versus or greater than 50 nanograms per milliliter versus less than 20 to 30 nanograms per milliliter. And here we have new onset chronic kidney disease. This study used data from the UK Biobank without prior CKD at baseline, and during median follow-up of 12.1 years, there was about a 30% reduction for those with diabetes and no significant reduction for those without diabetes. Okay, so that's our results from these observational studies. Now, here's a study from the Hollick group, which shows that first of all, many of the vitamin D's effects are due to the hormonal metabolite of vitamin D, which is 1,25-dihydroxyvitamin D or calcitriol, binding to a vitamin D receptor in cells, thereby affecting gene expression. What they showed when they randomized 30 healthy adults to receive 600, 400,000, or 10,000 IU per day of vitamin D for 6 months, there was a dose-dependent 25 of each alteration in broad gene expression with 162, 320, and 1289 genes up or down regulated in their white blood cell. The assumption is that if vitamin D causes the changes, it must be beneficial. So observational studies suggest the following points. First, randomized controlled trials and other vitamin D supplementation studies, even observational studies, should be based on participants with serum 25-OH concentrations below 20 nanograms per milliliter. Participants in the treatment group should be supplemented with variable vitamin D doses up to 10,000 IU per day with a loading dose in the first 1 to 2 weeks. That's to jumpstart the study. If you did not jumpstart it, it would take up to 3 months to get them up to whatever the saturation level would be. Participants in the control group should not be supplemented with vitamin D. Unfortunately, it's considered unethical not to supplement people in the control group with vitamin D because that's considered the normal basis of treatment. However, there was a study of Bruce Hollis conducted with colleagues in Iran where the baseline was 11 nanograms per milliliter, and they showed very, very good results for achieving greater than 20 nanograms per milliliter for pregnant women. Outcomes should be analyzed according to achieved 25 OH concentrations and BMI categories. That's because there are many ways that the vitamin D concentration changes with respect to vitamin D concentration. It includes BMI, it includes genetics, et cetera, et cetera. And so you cannot assume that one dose has the same result for all participants. And as found in a number of studies, people with higher BMI do not get as much benefit, if any, from vitamin D supplementation. Now, I just found this paper today at PubMed. It shows that that median serum 25-OHD or vitamin D concentrations among Americans in cross-section studies as measured by NHANES. Now, NHANES sends trailers to the southern United States in winter and the northern states in summer. And what they found is that from 2000, 2001, the mean value was 25 nanograms per milliliter. By 2022 or 2022 or 2023, 24, it was up to 31 nanograms per milliliter. And this is about a nanogram per milliliter change. This is likely due to reports from observational studies, since most of the clinical trials, most of the RCTs, have not reported beneficial effects. So I think this shows that we've been doing a very, very beneficial service over the past 10, 15 years. It's been sort of, I call the golden age of vitamin D, in which the non-skeletal benefits of vitamin D have been recognized and studied. Now, normally it's said that association is not causality. Okay, but A.B. Hill in 1965 gave a talk to the Royal Society of Medicine in London, in which he outlined his criteria for causality in a biological system. And as appropriate for vitamin D, they include strength of association, consistent findings in different populations, temporality, biological gradient, plausibility such as mechanisms, coherence with known science of the day, experimental verification such as randomized controlled trials or other vitamin D supplementation studies, analogy, and adjusting for confounding variables. There have been over 20 such analyses with vitamin D for health outcomes reported in PubMed, nearly all of them showing that the criteria for causality are generally satisfied. Now, not all criteria need to be satisfied for causality to be claimed, but the more that are, the better. And most of these said that, well, the randomized controlled trials are missing. Hopefully that'll be rectified in the next few years with better studies. Thank you for your attention.
Thank you so much for that, Dr. Grant. It's such an important topic to really emphasize the importance of the totality of evidence, especially when randomized controlled trials are very poorly designed for nutrient studies, something that Dr. Robert Haney spoke about quite frequently. So next up, we have Dr. Edward Giovannucci, who is a physician, epidemiologist, and internationally recognized nutrition researcher whose work has significantly advanced understanding of the relationships between vitamin D, diet, lifestyle, and chronic disease prevention. He serves as professor of nutrition and epidemiology at Harvard T.H. Chan School of Public Health. His extensive research has focused on cancer epidemiology, metabolic health, and the role of vitamin D and other nutritional factors in long-term disease risk. And he has authored hundreds of scientific publications contributing substantially to the scientific evidence informing public health recommendations related to nutrition, lifestyle, and vitamin D status. And today he will be discussing insights from randomized controlled trials and Mendelian randomization. Thank you, Dr. Giovannucci.
Thank you, Jen. It's a pleasure for me to be here. I will talk mostly about RCTs, very little about Mendelian randomization studies, and I will be talking about RCTs, but most of my work, well over 90%, is from observational data. So, just for a little bit of a background. Now, like randomized trials are critical part of the evidence, of course, and for some people that's all they accept. but I think that's a little bit simplistic. Now, for chronic disease, the randomized trials, there's really an imbalance in how you interpret the data. Now, a positive result in a strong, well-done randomized trial is very strong evidence for a causal effect because it's the most definitive way to exclude confounding factors. Um, but a null result needs to be carefully interpreted in the context of many factors that push the tendency towards a false negative. And I can't go through all of these. This would be a lecture unto its own, but this is a list of 9. I'm sure there are more factors that have been documented in my course. Each one of these I can spend a lecture on that impact randomized trials. So unless you really mess up a randomized trial and like the randomization process or something, if you do a reasonably well done randomized trial, you could still get a false negative because of all these factors. And for vitamin D or for any nutrient, it's particularly important to take into account the status of the population for that nutrient. It's different from a drug where you either, you take the drug or not. But for a vitamin, we all have an underlying status, which makes it important. Now, the biggest trial and the one, I mean, I was peripherally involved in this, but it was led by Doctors Manson and Julie Buring. And this is probably the most well-known large trial was VITAL. And this had about 26,000 men and women. You can see the ages, and they randomized to vitamin D or placebo. They also had fish oil, but we don't have to consider that. You can just look at the vitamin D. And so about 13,000 got 2,000 units of vitamin D, and 13,000 got a placebo. And this was about a 5-year study and looking at major endpoints. Now, the results started coming out about 2019, and one of the first reports was for major cardiovascular events. And as you can see, not much going on up to 5 to 6 years. The placebo and the active group had the same cumulative incidence. And for invasive cancer, pretty much the same, not much difference, a slightly lower risk, 4% non-significant lower risk in the vitamin D group. Now, results like this led some to be very skeptical of vitamin D. I'm sure people here are aware of, and there were some editorials saying results from VITAL and other studies really put a dent in the vitamin D, even making very strong statements like stop recommending vitamin D supplements. But we really have to look at the details of the trial. And so in this slide, we show this is from UK Biobank for cardiovascular endpoints and for fractures. And you can see the dose response. These are observational data. So in these studies, when you get around up to maybe 30 nanomoles vitamin D, 10 to 15 nanograms, you get most of the benefit. Then it's pretty flat. And in VITAL, the people, as Dr. Grant, mentioned in trials, for ethical reasons, you don't often start with deficient. That would be the good scientific question, but we already acknowledge that people shouldn't be very deficient in vitamin D. So in VITAL, essentially you can interpret what's going on from the mean of the population was around 30 and increased to about 42 nanograms. So these are averages, and averages don't tell the whole story, but at least this gives you a sense of what's going on. And you can see here that if you look at VITAL, so this is roughly what the control group achieved, and this is the intervention. And you can see, like you would predict no response based on the observational data. Most of the response would be in the lower levels of vitamin D. Now, having said that, there are, I think, some very positive results from VITAL that sometimes get ignored. So for cancer mortality, which was a pre-specified endpoint, you can see that there is a reduction, and it's biologically plausible because you wouldn't necessarily expect a reduction at, at time zero. If you start taking vitamin D today, I don't think your risk goes down immediately for an endpoint like cancer mortality. And you see very plausible after 3 to 4 years a reduction that actually got stronger when we excluded the first 2 years of follow-up, which was pre-specified, and you had a 25% reduction in total cancer mortality. That's a pretty remarkable reduction. And when we actually looked at uh, the endpoints in these large trials, it's hard to get very clean endpoints, but when we get the very clean endpoints, looking at medical records and making sure these are cancers, there was a statistically significant 37% reduction in total cancer mortality. That's pretty impressive. Uh, now, Vital was the largest trial, but there were a few other trials, and we did a meta-analysis looking at total cancer mortality. And if you put there like 3 trials that had daily dosing, you actually get a 13% reduction that was statistically significant, and not much seen with the trials that had large bolus supplementation, which is an issue of unto itself, but the daily dosing did actually, so the available trial evidence do support a reduction in cancer mortality. Another area where vitamin D is potentially important is immunity. And in Vital, when you looked at total confirmed autoimmune diseases, you actually did see a reduction, 22% reduction, that actually was stronger when you uh, excluded the first 2 years. Again, you wouldn't necessarily expect an immediate benefit on a chronic disease. So there was about almost a 40% reduction that was highly statistically significant. I view that as a positive result. Now, for diabetes, there were, this actually is not Vital. These are 3 trials, the combined data from 3 trials that were in individuals specifically with pre-diabetes. And the trials gave the doses were 3,000 IU daily, 4,000 IU, and then this is an analog of vitamin D, calcitol. And you can see there was actually a statistically significant reduction, about 15%, 17% if you exclude participants who basically were not taking the medication. So, but the intent to treat, which is the most conservative result, did give a positive result. And interestingly, in those with prediabetes, this is 10 trials. And one endpoint was that they regressed from prediabetes to normal glucose. And you can see every trial was in the right direction. I mean, some were small and had wide confidence intervals, but you put the studies together and there was a highly significant, statistically significant um, uh, reversion from prediabetes to no indication of diabetes, normal glycemic. So these are, pretty impressive. Now, we talked a lot about body mass index previously. You need higher vitamin D. In Vital, you can see when you stratify by BMI, these are the baseline levels of vitamin D. You can see that the leaner people had higher levels. And so the leaner people actually were already above 30 on average. And you can see they levels went up and a little bit higher in the vitamin in the lean group. Now, it's become evident that for lots of endpoints, we see benefits mainly in the leaner. So BMI 25, this is for any type of metastatic cancer, highly statistically significant, very highly significant, and interaction that's significant, a 44% reduction in total cancer, metastatic cancer. Now, remarkably, for invasive cancer, we actually did not see a reduction in overall in Vital, but there was a 24% reduction in those that are lean. So even for incident, not just cancer mortality. For autoimmune diseases, which I showed, that most of the benefit was in people with BMI under 25. And then in the diabetes data that I just showed, they also stratified by BMI under 31, which was the median. And that's where they saw all of the benefit. So it's actually quite remarkable that in these four separate analyses, highly significant interactions show up, which I don't think is chance. The other point, briefly, I think that's an important finding from Vital that I think is sometimes ignored is that in terms of toxicity, like sometimes studies show that there's no toxicity at high levels, but one counter argument is that like, well, these studies are short term, like in 6 months you may not see toxicity, but maybe for long term high levels. But in Vital, there was absolutely no evidence for toxicity, hypercalcemia, anything. So essentially, it shows long-term, up to 6 years, going from around 30 to like 40 to 50 nanograms. There's no evidence of adverse effects. So that does away somewhat with the long-term, things that we're missing if with long-term, relatively high levels. And then this is actually the only slide I have for Mendelian randomization. Mendelian randomization, it's a complex to process to interpret. I think it could be useful, but sometimes over-interpreted, sometimes under-interpreted. But the main point I wanted to make is we actually did a summary of all the Mendelian randomization studies in vitamin D and multiple endpoints. And believe me, there's a lot of interest in this. We had to go through over 100 articles. And I list here where there are positive signals. And I'm not claiming that this proves a causal effect, but the nice thing about Mendelian randomization is that it's complementary. It's not perfect, but because it's looking at genetic factors, it's not confounded by lifestyle or other factors. So it does give independent evidence, and it's a genetic factor that gives you some indication of long-term status because your genes don't change over life. So this is kind of like looking at individuals with genetically slightly higher levels of vitamin D. And for all of these endpoints, there was evidence of benefit. So just in summary, so RCTs are an important component of the evidence for vitamin D, but I think we need to interpret results cautiously, and many factors can cause a false negative. The actions of vitamin D are likely to be pleiotropic. For some conditions like CVD or fracture, perhaps all you need to do is to avoid severe deficiency. For others, uh, cancer, autoimmune disease, diabetes, high levels and doses are likely needed. Emerging evidence suggests high adiposity blunts the actions of vitamin D's, and benefits of supplementation are clear in those without obesity. And long-term RCTs show that attaining levels up to 50 nanograms for multiple years show no evidence of harm. And I think due to time, I will end at this point. Thank you.
Thank you very much, Dr. Giovannucci. So now we get to enter the realm of vitamin D and pregnancy. And up next is Dr. Bruce Hollis, who is a nationally recognized vitamin D researcher and was professor of pediatrics at the Medical University of South Carolina, where his work has helped shape modern understanding of vitamin D metabolism during pregnancy, lactation, and early childhood development. Over several decades, Dr. Hollis has authored hundreds of scientific publications and is especially well known for his research demonstrating the importance of adequate vitamin D supplementation during pregnancy for maternal and infant health outcomes. Dr. Hollis has played an influential role in advancing scientific and clinical discussions surrounding prenatal vitamin D recommendations, helping to build the evidence base supporting higher maternal vitamin D intake and routine monitoring during pregnancy. Welcome, Dr. Hollis, and you wanted me to share your slides for you. So let me pull those up.
All right. So this is work that's been going on for at least 30 years. And I'd like to thank NIH for the funding that they provided. And so let's go to the next slide. So here you have the recommendations to go back years. So what we are told essentially by the IOM and before, that the requirements for the subject on the left were identical or slightly different than the person on the right, and that if you supplemented to these levels, which was 200 to 400 units a day, that everybody would be okay. So if you give the infant 400 units of vitamin D and you measure 25 hydroxy in their circulation, you get a profound increase in circulating levels. However, if you give that same dose to Mr. Atlas here on the right, you don't even see a response. Next slide. How toxic is vitamin D? And unfortunately, you're going to have to hit these to advance the slide. The guidelines state that prior to 2000, that you could not take more than 2,000 units of vitamin D a day. This is from the 1997 IOM recommendations, or it would be toxic, and those are ridiculous statements. That was an error, an impediment to health. The new IOM that's been talked about is 4,000 units a day, which is much better. And the truth is, intakes of 10,000 we know today are totally safe. So the IOM position reported that an optimal circulating level of 25D would be 50 nanomoles or 20 nanograms. The IOM also states that a level of 120 nanomoles are potentially harmful, and that this is odd in the human beings for millennia. 25 hydroxy levels have far exceeded this. So, public health issue for vitamin D during pregnancy. So, Carol Wagner and I, this is going back in 2001, looking at the recommendations, looking at what we saw in the clinics, looking at what we saw in our babies. It was evident in our minds that vitamin D deficiency during pregnancy was a serious health issue that affect both mother and fetus. And we needed to establish the vitamin D requirements of pregnant women as seen as vital to preventing vitamin D deficiency. Yet, the Institute of Medicine made only slight changes in the recommendations for vitamin D. So if we go fast forward or go in a rear to 2002, we wanted to do a randomized trial in pregnant women. Okay, so we designed this study, and at the time, it was designed as a safety study. How much vitamin D did pregnant women need to normalize their circulating levels? We looked at a few things, like we were looking at the maternal skeletal integrity in infant, because to be honest with you, all the things that are important that we know today, like prevention of preterm birth, preeclampsia, gestational diabetes, asthma, which is going to be talked about later by Dr. Weiss, we didn't even know to ask those questions. Okay, so we had to go with the data and the information that we had, and we defined this study, wrote an NIH grant, big clinical grant for the time, got a great score. And when we came back from the study section, we got the comments back that they said, well, this is all great, but at the time the UL was 2,000 units and you want to give pregnant women 4,000. Wait a minute. Okay, so they forced us to go to the FDA and write an application that essentially pharmaceutical companies had to write to conduct pharmaceutical studies. And so we had to get an IND number from the FDA. Never had anybody been required to do that for vitamin D, but we were required to do it. So this initial study that was started in 2002 or 2003 was a randomized trial of 400, 2,000, or 4,000 units of vitamin D per day. Women, this is all published. And anybody has any questions, they can contact me, and I'll go over this. But this was published in 2011, I believe. It's been cited well over 1,000 times. So we did this study. It was monitored like a hawk by the FDA. All right, and we had this IND number, which was accessed by many people after to do many clinical studies outside of pregnancy, because we had this drug approval number to do these studies. So as I said, it was monitored for safety, efficacy, with monthly 25Ds, 125. There was data monitoring committees that had to watch over all this. And for adverse events. Let's go to the next slide. Okay, so we published the initial data, okay, in 2011, all the safety data, all the blood levels, all the adverse events, which were zero attributable to any vitamin D supplementation we were doing. So we found out what women, what the levels of 25 would do during pregnancy. These women started in the study in the first trimester, which is about 12 weeks or so, because that's when you see women coming in for pregnancy. The truth of the matter is that's really a weakness in these studies, because a lot goes on in that first trimester where all of these women with vitamin D deficiency, when adverse events could be happening due to vitamin D deficiency, and you have no control over it because they haven't entered your study. But when we went back a couple of years later, when we knew that we could ask these questions, we went back and looked at the data, and lo and behold, in a randomized trial, although it was not an intent to treat fashion, because these endpoints were not defined in the original study. Again, we didn't even know to ask these. So we went back and did this. And so if you look at the blue numbers on here, okay, those were significantly different when women got higher doses of vitamin D. These complications of birth that we saw were actually real in a randomized trial. Okay. I think I presented this maybe initially in 2009 and at a vitamin D meeting, and was brutally attacked. How can vitamin D have anything to do with this? Why are you even asking these questions? So this is the kind of hostility that we faced when we first started presenting this data, that vitamin D really would have an effect on complications of birth. Next slide. This slide was a study that was done by Dr. Savlak in India. And as mentioned earlier, if you want to do vitamin D studies in our country or largely in Europe, you have to have the control group has to meet standard of care, okay, which means pregnant women have to be prescribed a certain amount of vitamin D that they would get if they were being followed by a OB, and which is 400 to 600 units. Okay, you can't do a study and give anybody zero, right? Even though, as it stands in our medical care system, many people, especially minorities, are going through pregnancy exactly in that fashion. They're not being treated, they're not taking their supplements. So what happens if you conduct studies where you have a deficient population? And this particular study was run in India. This was published in 2015 in Clinical Endocrinology by an Indian group. And what they did was that they took a population of women. Half of them got supplemented with vitamin D. It was bolus supplementation, which wasn't ideal, but it has its advantages because it's 100% compliance versus compliance problems when we did our study that are largely unavoidable. But in the end, when they looked at these groups, okay, of placebo, which means there was ongoing vitamin D deficiency the entire pregnancy, okay, as opposed to the supplemented group, which were intervened, and there was a massive decrease in gestational diabetes, preeclampsia, and preterm labor. All right, totally ignored by mainstream media. Next slide. This study was published in 2018 and it was done in Iran, under the same type of protocol that was performed in the Indian study, meaning you had a large group of women who were uniformly vitamin D deficient who entered the study, half of which got treated, half of which did not. It was a very complicated field trial, essentially a randomized trial. The results were frankly just incredible. Okay, next slide. So when this paper was done and submitted to the places where people want to put high impact, New England Journal, JAMA, British Medical Association, one universal thing happened. They all rejected it. They said, nope, we're not publishing that. But if you look at the results from this Iranian study in this hazard ratio, and if you look down here, it's preeclampsia, preterm delivery. Every single one of these things was dramatically decreased. If you look at the effects of true supplementation into a vitamin D depopulation, and I would relate this back, I don't have any evidence per se, but this would be what our minority populations who get very poor nutritional care and prenatal care, this is what it would look like if you ran a study in our country where you gave no vitamin D supplementation to that group and then intervened in the other group. Unfortunately, I mean, we just can't run that kind of study in our country. Lactation. It's well known that human milk is a poor source of vitamin D for the nursing infant. This goes back forever. Okay. It's true in the fact that human milk is supposed to be the perfect food, except if a nursing infant it was his sole source of nutrients, they could get rickets. And so we asked the question, how can this happen? How could human milk be replete in other nutrients, but in vitamin D, it's deficient to the point that the infants could get rickets from consuming only vitamin D breast milk. Next slide. So Carol Wagner and I, again, conducted this study, which led to getting another big NIH grant. And what we did was we gave how much vitamin D would women have to get to make their milk adequate. Okay, so the common practice was a nursing infant would get 400 units of vitamin D orally and nursed from the mother. But what if you could give the mother enough vitamin D? How much would that be so that you wouldn't have to do that? The woman could take it herself, enough vitamin D would pass into her milk, and she would pass it to the infant. So we carried that study out, and this is measured at levels of milk in the mother and the baby. So go to the next slide. And what we found was when we gave women 6,400 units of vitamin D, she passed plenty of vitamin D into her milk. So you no longer had to supply the nursing infant with supplemental D. That infant was getting plenty of vitamin D just through the mother's milk. So next slide. We designed another NIH study that was carried out at our place in the University of Rochester. There were we had 3 different groups again, 400 a day to the mother, 2,400, 6,400. Again, it's the FDA monitored study. Next slide. By 2 months, the maternal 25D differed significantly among treatment groups. And what we found was the infants that were getting their milk from mothers who had higher levels of intake of 6,400 to replete their milk did just fine. They were the same as a standard of care, which an infant would get 400 units. So it gave pediatricians an option to either recommend supplementation directly to the infant and nursing, or the mother could take substantial amounts of vitamin D and supply the infant directly with her milk. And actually, that's in use today. I don't think it's in use as much as it should be, but I know in certain practices, in pediatric practices, the pediatrician is giving that option. It has never made any headway in any of the official recommendations in Pediatric Society that they go that route. It's still just give it to the baby, the mother, don't worry about her. And in this study, again, we never saw one single adverse event due to vitamin D supplementation. It was totally safe. And I always thought it was much better to go this route than give it, because oftentimes mothers stop giving the vitamin D to the nursing infant because it's a pain. Infant doesn't like it. They just don't do it. So, and there's real risks to not doing that. Next slide. So the conclusions, mothers currently taking 400 units of D will not provide adequate vitamin D in her milk for a nursing infant. You need intakes up to 10,000. When you give my own family has done this, 10,000 units. Kids were great, infants had plenty of vitamin D. And vitamin D is essentially during pregnancy, not only for skeletal integrity, which is relatively requires minor amounts, but also the complications of birth, such as preeclampsia, preterm birth, neurodevelopment, which I think Dr. Wagner. But I just want to relay one additional thing. We've said that vitamin D really could be used to prevent preeclampsia or preterm birth. And several years ago, it was more than 10 years ago, a small drug company came out with an injectable called 17-hydroxyprogesterone. It was used to prevent preterm birth. It was given preliminary FDA approval. Okay, so it became used in clinics when women would go into preterm labor. And there was only one problem. It didn't work. But this company, which was purchased by a bigger company for $700 million, continued to market this until about maybe 2 or 3 years ago when they promised to give more data, never showed up, and the FDA actually pulled the plug and wouldn't let it do it. So there's currently no treatment to stop preterm labor. I don't think I'm mistaken in that, but there is currently no approved treatment where this is looking physicians in the face and saying, if you do this, especially to high risk populations, you will prevent a lot of that preterm labor and preeclampsia. Thank you.
That was great. Thank you, Dr. Hollis.
Dr. Carol Wagner is a neonatologist, researcher, and professor of pediatrics at the Medical University of South Carolina, whose research has focused extensively on maternal, fetal, and infant vitamin D health. Working closely with Dr. Hollis, Dr. Wagner has co-authored numerous landmark studies examining vitamin D supplementation during pregnancy and its impact on maternal outcomes, infant development, immune health, and pregnancy-related complications. Through her decades of clinical research and scientific publications, Dr. Wagner has become a leading voice in the field of prenatal vitamin D research and has contributed significantly to ongoing discussions regarding vitamin D recommendations and maternal child public health policy. Welcome, Dr. Wagner.
My talk is entitled Vitamin D Deficiency in Pregnancy, an Overlooked Modifiable Driver of Maternal and Infant Outcomes. And I thank you for this opportunity to speak today about something that obviously Bruce and I have been working on for a few decades. And I'd like to focus on what happens clinically and biologically when vitamin D requirements during pregnancy and lactation are or are not met. Next slide. So, as you've just heard from Dr. Hollis, vitamin D requirements during pregnancy and lactation are higher than historically recommended, and importantly, these levels are safe and achievable. The question I'd like to address is what happens when those requirements are not met, and so biologically and clinically. Vitamin D deficiency remains common among pregnant women in the United States. It disproportionately affects racial and ethnic minority populations, and it is associated with meaningful clinical outcomes. So we see increased risks associated with vitamin D deficiency linked with preterm birth, pregnancy complications such as preeclampsia, and certainly altered immune and placental function. Importantly for this audience, vitamin D status and deficiency are measurable, and the whole aspect of deficiency is modifiable. So who's most affected by vitamin D deficiency? So Black women, they're 20 times more likely than white Caucasian women. Hispanic and obese women also are at higher significant risk of vitamin D deficiency. These same populations already are at higher risk for adverse pregnancy outcomes, so vitamin D deficiency may be compounding existing disparities. Next slide. In a real-world cohort of over 15,000 pregnancies that were women were followed at the Medical University of South Carolina, we see a consistent pattern that vitamin D status is strongly associated with preterm birth. Next slide. In this cohort of over 15,000 pregnancies, we observed a clear and consistent relationship between vitamin D status and preterm birth. So women delivering preterm had significantly lower 25 OHD concentrations, and those with severe deficiency, as you can see, less than 12 nanograms per ml, had nearly double the rate of preterm birth. Importantly, this follows a dose-response relationship, which strengthens the biological plausibility of this association. And as Dr. Grant said earlier, looking at association does not translate into causality, but there certainly is a strong association. Next slide, please. So taken together with earlier randomized trials and these combined data sets, which we have listed here, we've published extensively, we now see a consistent inverse relationship between vitamin D status and preterm birth across more than 2 decades of research. These findings really support the screening and addressing vitamin D deficiency that the effect it could have, and it represents a cost-effective strategy to reduce preterm birth. And as Dr. Hollis mentioned, there really is no, I'm a neonatologist, and so there is no, at this time, we have drugs that may delay contractions and so forth, but we really do not have treatment for preterm birth. Next slide, please. So the next question is whether there is biological plausibility between this association. Next slide. To step back and take a broader view, the data from the Kellogg studies and others suggest that vitamin D is not acting through a single mechanism. Instead, it operates across 3 major biological systems that are central to pregnancy. First, at the level of the placenta, we see effects on angiogenic signaling and placental development. Second, in the immune system and microbial environment, vitamin D influences immune mediators and is associated with differences in the vaginal microbiome. And third, at the level of fetal programming, there are epigenetic effects that may influence developmental trajectories. So rather than thinking of vitamin D as a single nutrient with a single function, which I think we're led to think that because we measure 25 hydroxyvitamin D or 125 and we see this association or this tendency of one measurement, one single function. The evidence suggests it is acting across interconnected systems that are directly relevant to pregnancy outcomes. Next slide, please. So vitamin D, as we've recently argued in the American Journal of Clinical Nutrition editorial, vitamin D in pregnancy is better understood not as a single nutrient or dose, but as part of a developmental system that's operating across maternal, placental, and fetal biology. Next slide, please. One of the questions I increasingly find myself asking is what, from an evolutionary perspective, actually represents physiologic normalcy during pregnancy. And we've heard about these studies. And so Lux Walda and colleagues published looking at traditionally living East African populations in a sun-rich environment and found that pregnant women naturally maintain substantially higher vitamin D concentrations than are typically observed in Western populations. And following giving birth, there's a rapid postpartum decline. And to me and others, these findings suggest that pregnancy itself may represent a unique developmental and physiologic vitamin D state. And I think that we have to apply that through the lifespan. Next slide, please. So if we extend this premise beyond pregnancy, the next question is whether these effects continue into lactation and early life. And what we see, emerging data suggests that vitamin D does not just transfer into milk. It may influence the composition of milk itself. In particular, we see differences in human milk oligosaccharides, which are critical for immune development and the infant microbiome. And this raises the possibility that maternal vitamin D status is shaping early life biology through human milk. We've also seen differences in the proteomic profiles of women who are vitamin D replete versus those who are deficient over time. Next slide, please. And importantly, these effects do not appear to stop at birth. Next slide, please. So beyond pregnancy, the effects appear to extend into early brain development across multiple cohorts, including our own and international studies. Higher early life vitamin D status is associated with better neurodevelopmental outcomes using validated objective measures of neurodevelopment. Conversely, maternal deficiency during pregnancy, particularly later in pregnancy, is associated with suboptimal neurodevelopment. Next slide, please. So what we're beginning to see is that vitamin D deficiency may influence a developmental trajectory extending from pregnancy and into early childhood. And I also opine that it extends throughout the lifespan. So beyond pregnancy itself, maternal vitamin D status appears to affect human milk composition, including components involved in shaping the infant immune system and microbiome, and across multiple cohorts. Higher early life vitamin D status has been associated with better neurodevelopmental outcomes. So when we combine these findings, it suggests that vitamin D is acting across interconnected developmental systems during critical early life windows that persist across the lifespan. Next slide, please. So again, taken together, these data suggest that vitamin D deficiency in pregnancy is not simply a nutritional issue. It is common, it is disproportionately affects vulnerable populations, and it's associated with outcomes that matter, from preterm birth to early childhood development. And most importantly, it is measurable, preventable, and treatable, and addressing vitamin D deficiency represents a safe, low-cost opportunity to improve maternal and child health outcomes. Next slide, please. So in closing, vitamin D deficiency, as we've seen and is shown, is common in maternal infant health. Ultimately, this represents an opportunity to improve maternal and child health, not only through the treatment of deficiencies, but also through earlier support of biology during critical periods of human development. Next slide. Thank you.
All right, that was fantastic. Probably my favorite subject when it comes to vitamin D. Thank you, Dr. Wagner. All right, so we now have Dr. Scott Weiss, who is professor of medicine at Harvard Medical School, co-leader of the Systems Genetics and Genomics Unit, and associate director of the Channing Division of Network Medicine at Brigham and Women's Hospital. He has been continuously NHLBI funded for 48 years, with more than 1,000 publications, an H-index of 190, and he has been recognized among the top 0.004% of biomedical researchers for his scientific impact. He is also an international expert on clinical trials in asthma, including the VIDART trial. All right, welcome, Dr. Weiss.
My presentation and Human Mirzakhani's presentation are sort of coordinated. I'm going to present sort of what we learned from VDART, and then he's going to talk about what the next trial in pregnancy might look like. So next slide, please. So in 2004, I was doing asthma genetics and genomics, and we identified the vitamin D receptor as a gene for asthma. Then we did 2 observational studies where we demonstrated that maternal intake of vitamin D, mostly from supplements, was associated with about a 50% reduction in asthma wheeze in the offspring of the mothers. Uh, um, and after those observational studies, we designed and got funded by NHLBI the vitamin D antenatal asthma reduction trial, the schema of which is shown on this slide, where we enrolled women between the 10th and the 18th week of pregnancy, had blood draw at entry and at 32 to 38 weeks, randomized the women to 4,000 IU plus 400 IU in prenatal vitamins versus prenatal vitamins alone, which was 400 IU. Followed them to make sure that they didn't have any adverse complications from the treatment. Looked at the mother at 1 year and the child at 1 and 3 and 6 years. There were absolutely no complications whatsoever of the 4,400 dose. Why did we use 4,000? Bruce explained it in his talk. He had the IND for 4,000. If we had tried to use a higher dose, we would have had to go through the FDA and get a separate IND. His paper, dosing paper, had not yet been published when VDART started, so the path of least resistance was to go with the 4,000 IU. Next slide. So what did we learn? Well, the effects of vitamin D treatment were statistically significant at 3 to 6 years for both asthma, wheeze, and for lung function at age 6 when we did a level stratified intent to treat analysis. What's a level stratified intent to treat analysis? It's basically considering the amount of vitamin D in the control group and controlling for that, and then doing the standard intent to treat analysis. If you do just the standard intent to treat, the results were borderline significant at 3 years, not significant at 6. But if you do the level stratified intent to treat, which controls for the amount of vitamin D in the control group, the results were statistically significant. We did a meta-analysis where we actually showed that we could recover exactly the same effect, a 50% reduction, as was seen in the observational studies. We also showed that the earlier in pregnancy that the women enrolled in the trial and got on treatment, that there was an effect. Obviously, nutrient trials are fundamentally different from drug trials because there is contamination of the control group in nutrient trials. You see this in Vital, as Ed presented. The level of vitamin D in the control group in Vital is exactly the same as in the treatment group at the start of the trial. They never did a level stratified intent to treat in Vital, but it would be a useful exercise to carry that out. This method of analysis was initially proposed by the late Bob Heaney as a way of overcoming the effects of effects of vitamin D in the control group. So next slide. Time of enrollment matters. The window for airway development in the fetal lung is between the 5th and the 10th week of pregnancy. So in VDART, we were enrolling people between 10 and 18 weeks, but ideally you would get them at conception. I agree with what Carol said. This is a continuum. Vitamin D is necessary at every stage, from the point of conception right through the first few years of life. Dose matters. The higher the dose, the better. At the 4,000 IU dose, 70% of the women in VDART achieved a level of 30 nanograms or better. But the ones who did not were the women who were obese. And that was 30% of the women who never got to 30 nanograms per ml despite the 4,000 IU. So BMI matters. It matters in pregnant women. Higher BMI is associated with preterm birth. It's associated with preeclampsia. And these adverse pregnancy outcomes, both preterm birth and preeclampsia, are major risk factors for childhood asthma wheeze and also for neurocognitive development. So all of these outcomes are interrelated and part of more of a systems approach to these health outcomes. I would like to point out that each one of these is about a $12 billion a year cost to the healthcare system. Child asthma wheeze, 40% of kids wheeze in the first year of life. That's down to 20% by age 6. Of half of those are actually diagnosed as having asthma. And then obviously the collection of omics samples is critical to the interpretability and the biologic understanding of clinical trials. And so that was something that we did in VDART. It's been very important, paid off in a big way. Next slide. So 50% reduction, you could probably, at a suboptimal dose, we could probably get to 85% reduction in asthma wheeze if we were at an optimal dose. The risk of asthma wheeze is a continuum. It's not categorical. The higher level of vitamin D, the earlier in pregnancy, the lower the risk. Long-term protection is linked to change from the baseline level with the intervention, and prevention is directly linked to early intervention, with preconception being the optimal. And this optimal serum level is 60, not 30. To give you an idea of the magnitude of the problem, 70% of pregnant women have levels in the United States have vitamin D levels less than 30. 99 to 100% have vitamin D levels less than 60. I think that's my last slide. Just want to acknowledge the people who worked on VDART, and Bruce, who was on our key member of the control data safety group at the Channing. So I'll end there and turn it over to Human.
All right, I'll introduce him first real quickly, and thank you for that. Dr. Human Mirzakhani is Assistant Professor of Medicine at Harvard Medical School and Faculty Investigator at the Channing Division of Network Medicine at Brigham and Women's Hospital. His research focuses on maternal and child health, particularly adverse pregnancy outcomes, early life respiratory disease, and modifiable prenatal exposures such as vitamin D. Today, he will discuss trial design considerations for optimizing vitamin D supplementation in pregnancy to improve maternal and child outcomes. All right, welcome.
Thank you so much. I appreciate it, and thanks for having me. And I just mentioned that I had the honor of working with Dr. Weiss last 13 years, and glad to present here. So previous talks paved the way for me, make it easier to summarize things and approach about the future vitamin D supplementation during the pregnancy and how we can optimize that and what are the practical issues that we should consider that. So the key question about the trial is that we know that why do we need another vitamin D trial in pregnancy? There is no doubt that pregnancy is a key window during the life, and because of the placentation and fetal development in different areas. Dr. Weiss talked about the effect of vitamin D on early lung development and also the brain development and neurodevelopmental development in fetus. So we know that supplementation could reliably increase vitamin D even with low doses, but different trials tried different doses and the outcome was remained still mixed. Some of them, they got the results, some of them after doing the secondary analysis, and some of the studies were solely just like observationals. As mentioned, prior trials tried different doses and they start at different time, they target different population, and also the primary endpoint was different too. So that makes it a key point for the next trial to answer an optimization question, meaning that who and when and what level and which outcome should be considered and to be approached. Definitely, there are different outcomes to be considered for the effect of vitamin D supplementation. And based on the current evidence, adverse pregnancy outcome, child asthma, and neurodevelopmental the disorders are on the top layers that they have evidence in support of the preventing of them. Definitely for a short trial design presentation, we can have two competing concepts, which one could be a pragmatic approach and the other one could be a mechanistic approach and gives us more information that how vitamin D works. in presentations before, it was very helpful that the dose was discussed about the reliable dose and what is they're based on the different recommendation like IOM, Endocrine Society, and ACOG, all has different recommendation between 600 up to 5,000, and it was well pointed that up to 10,000 international unit per day is safe and no toxicity has been reported in terms of the vitamin D supplementation in adults and pregnancy. But in trial design, there is one key point that dose alone should not be the central controversy. There are so many other factors. Early initiation, body mass index, as Dr. Weiss mentioned, baseline vitamin D level, and early target attainment, all of these factors that could be considered aligned with the applied dose. Definitely, doing the intent to treat analysis as primary is important. However, there are some other studies have already shown, including WIDAR, the achieved level and pre-specified stratified analysis by BMI could be very important too. One key, as I mentioned before, that maternal adverse pregnancy outcome, and also Carol mentioned too, and Dr. Hollis, that all of them could be as a composite outcome or individual outcome, preterm birth and preeclampsia has a specific importance because they also increase the risk of other type of offspring health issue related, such as asthma, and put them at neurodevelopmental disease risk. Overall, we know that the prior studies had been either underpowered for the right endpoint, or they applied low dose, or they applied different doses, or it started too late during the pregnancy. Or if all of these factors were considered, they failed to account for differential target attainment. I want to give you two Dr. Weiss talked about the BMI. In this slide that you can see that those who in REDART, those who received high dose of the vitamin D, at least 1/3 of them among the obese pregnant women, they remained vitamin D insufficient at the cutoff of 75 nanomole per liter, which equals to the 50 nanogram per ml. If we consider the cutoff of 20 by IOM, this drops to the 15%. Still, it's a very considerable rate that they did not reach to the sufficiency based on both of the cutoffs. And one interesting point that I want to share is about the as a cumulative exposure. So that's a very important factor that we did a pharmacokinetic analysis in REDART, and we assess the cumulative exposure to vitamin D during pregnancy. As you can see that AUC, area under the curve at zero, it corresponds to 30 nanogram per ml or 70 nanomole per liter. And each standard deviation above this level decrease the asthma and recurrent wheeze in offspring by 25%. And by 6 years, it was 70%. So the point is that the trial design should also consider, just in addition to the dose, not only the dose, late pregnancy level is important, but cumulative exposure across pregnancy is very important too. This could be also important because even if that they are receiving the supplementation for other factors, genotypes, and other things, there might be some fluctuations across the level throughout the pregnancy. So based on these factors that we discussed, we can just introduce two concepts or approach for a supplementation trial. The first one, I call it a pragmatic trial for feasibility, which we provide prenatal supplementation, and we consider the maternal primary outcome for the trial. The population target will be those who are in planning of the pregnancy, that's the ideal population, or enrolled less than 30 weeks of the gestation. And design will be double-blind randomization, which they will be randomized to standard prenatal versus higher dose vitamin D, similar to REDART, but definitely possible higher dose will be desired. And also based on the two approach could be considered based on the BMI. One approach with the single high dose across all BMI categories. The other one is to stratify the dose across the normal pregnancy, overweight, and obese. The primary outcome, as I highlighted, the adverse pregnancy outcome importance, specifically also Carol and Bruce mentioned, highlighted the preterm birth and preeclampsia. We have similar results in VDART, or also Bruce mentioned about the composite adverse outcomes, which there was a significant in one of the studies in the trial that he had. That's in association with vitamin D level. In such a trial, secondary child outcome will be secondary, which include asthma and the neurocognitive development, and we can consider that autism spectrum disorder as an exploratory long-term follow-up because they need to be tested at 8 or 10 years after the supplementation and the trial. Definitely, it's important to follow up maternal for hypertension and cardiometabolic outcomes. These are another area that vitamin D has shown some efficiency in prevention of them and affecting the maternal health. One key point that I want to mention in VDART that we have shown that preterm birth and preeclampsia increase the risk of offspring asthma and recurrent wheeze, and also affecting the developmental assessments. So these are all supporting AAPO-focused maternal trial design. However, if we want to have a more comprehensive approach, a more mechanistic, and just understanding which exposure window might be important comparing prenatal versus postnatal, then we should just consider a trial design of by maternal child supplementation, kind of a factorial design. And we have 4 arms, 2 arms as a control child maternal, 2 arms as a supplementation or treatment arm in child and maternal. In such a trial, primary outcome will be child outcome, child health, which include child recurrent wheeze and all asthma, and also the cognitive and neurodevelopment assessment and disorders at ages of 4 and 6 years, continued by 10 years for rarer outcomes such as ASD. And here, maternal APOs will be considered as a secondary outcome for the prenatal and all other prenatal disorders that we might just see during the pregnancy. BMI should be considered in the planned as a level stratified and along with the level stratified analysis and intent to treatment approach. Regardless of whatever any one of these 2 approaches that we consider, there are some key elements that should be harmonized and included in both of them. We should just start supplementation as early as possible. I mentioned that ideally pre-conception or at least less than 20 weeks of the gestation. Definitely, we should measure the baseline of vitamin D 25 hydroxy in all participants. And we talk about the importance of the BMI and stratify based on the BMI, include that either with different dose supplementation or we include it in the analysis. One other key point is that accounting for the baseline and 25 hydroxy D level, because as discussed by other presenters, it might not be ethical to only enroll those who have deficiency into the trial. And there might be some controls with higher level of the vitamin D levels. And also adherence, we have shown in VDART could be important factor at the level of for 10% change in adherence, we might have 1 or 2 unit differences in the level of the vitamin D. However, this level is different across the BMI category too. Another key point to consider is defining the target that we want to attain. And this is important from 2 aspects, not only by the level, by the timing. As soon as possible, we achieve the sufficient level. Ideally, we want to be more than 40 nanogram per ml. The result could be much, much different from just like a later. Some of the pregnant women with even with a high dose, they might reach after 3 or 4 months to that level. We also talk about considering the cumulative exposure, and that we should be included in as a pre-specified exposure metric in the trial, because it could just show how much on average during the pregnancy, pregnant women has been exposure to the vitamin D level throughout the pregnancy from the beginning to the end of the supplementation. And it's very helpful putting that in aligned with the adherence concept. And the key point is that not only how much vitamin D level is achieved, but it's important that we know how early and how sustained it is. And I put here a comparison of two approaches side by side, but regardless of either of them, a more comprehensive approach, a more pragmatic approach, the final message is that the next pregnancy vitamin trial should determine for whom, when, what level, and toward which outcome supplementation works best. So here, I just want to acknowledge all those whose work and just inform all these ideas. And also Dr. Weiss, Dr. Liton, we collaborated in BDOT for the last 13 years. Thank you so much.
All right, well, we are going to be going over time. I hope everybody can stick with us. We still have a few presentations and they should be pretty short, but if not, it's all good, right? We're all here to learn from each other, and this is going to be recorded and shared afterwards. So next up, we have Dr. Leigh Frame, who is Chief Wellbeing Officer at Good Bacteria, Executive Director of the GW Office of Integrative Medicine and Health, Associate Professor of Clinical Research and Leadership and Physician Assistant Studies at the George Washington University School of Medicine and Health Sciences. A translational health leader and microbiome researcher, her work focuses on the microbiota gut-brain immune axis and nutritional immunology, including a big focus on vitamin D. She co-hosts the GW Integrative Medicine podcast and co-founded the GW Resiliency and Wellbeing Center. Dr. Frame also serves as Chief Medical Officer of Recondite Consulting and advises multiple healthcare and biotech organizations advancing integrative pathways to well-being and whole person health. Welcome, Dr. Frame.
Thank you so much. So while I do a lot of things, I have no relevant disclosures to this particular talk. I'm going to talk about vitamin D and immune health and particularly focus on stress testing those two components. Let's get moving here. All right, so first, vitamin D is really important in immune competence, and physiological stress kind of stress tests those things. And what do we mean by that? So hospitalization, surgery, acute illness, these things are stress tests for the immune and metabolic system. And so at these time periods, we see an increased inflammatory burden, an increased immune demand, increased tissue repair, perhaps, and decreased physiological reserve. So we don't have as much leeway there, not as much resilience. And so basically what we're seeing here is the clearest consequences of low vitamin D status really emerge under these cases of physiological stress. So while a lot of the studies that have been presented so far are very meaningful, it may be that we could actually get a clearer picture by looking at these cases where there's this larger stress component. Okay, so vitamin D is really important for the immune system. It's important for a balanced immune response. Why is that? Well, vitamin D is actually an immune regulatory hormone. So while it's a nutrient, it's also a hormone and affects the way that our immune system reacts. It makes it act in more of a homeostatic way, the balance idea, right? So what's happening during balance is the immune system is surveilling. It's looking for pathogens, it's looking for cancer. Basically, it's doing its job, but it's not raising alarm. Now, if you have insufficient vitamin D, what happens is your immune system is going to be dysregulated. Now, what that means actually varies from person to person. It could mean autoimmunity. It could mean an inability to fight off infections. But every aspect of the immune system is really touched by vitamin D. So the innate immune system, that first line of defense, the adaptive response, those T cells and B cells that get in there and learn what's going on and really come to the rescue in the second line. Regulation of inflammation, so resolution of inflammation after an appropriate immune response. Vitamin D is really important for that. barrier integrity. So the ability of the different barriers inside our body to actually act as that first line of defense, really important to have vitamin D in that. Immune tolerance, I kind of alluded that already. Autoimmunity is a problem of immune tolerance, poor immune tolerance. So insufficient vitamin D really loses that immune tolerance aspect where we can, attack ourselves or attack food antigens, things that are inappropriate for the immune system to respond to. And then this last box over here is the one that I get most excited about, is it works in a system, right? We can't take this thing out and look at it by itself. So it's part of our metabolism, it affects our microbiome and the environment that our bodies are in. Okay, when we're talking about hospitalizations, infection, acute care, what are we looking at in the literature? So we've seen associations. Lower vitamin D status has been associated with increased respiratory infections, particularly upper respiratory infections, the ones that we often get the most, increased hospitalization risk, longer hospital stays, which I'm putting this asterisk here because the longer you're in the hospital, the more you're having that immune and physiological stress. So things can actually compound there. So this is one of those factors that we really want to put a pin in and say this one's really important to look at. And similarly, we see an increased ICU severity and worse critical illness outcomes in those that have lower vitamin D status. With a big caveat. So a lot of this is observational evidence, which we've talked a lot about today, and some of the issues with that and the RCT findings. And they're not always consistent, the observational evidence and the RCT findings. There's been a lot of discussion as to why that is, so I'm not going to beat a dead horse here, but just highlight a couple of potential reasons that really are important in this particular area. One being baseline variability. Where are these people starting? Are they coming into the hospital vitamin D deficient? That's likely going to increase their risk. And then a failure to achieve meaningful biological status, right? So if you're not giving a large enough vitamin D dose to actually improve their baseline status, you might not see the same thing in an RCT finding as you would in these observational studies. Surgical outcomes, recovery, and wound healing. This is actually what I did my doctoral dissertation on, so I'm a little bit passionate about this one. It's in many cases a factor that we can very quickly treat prior to surgery, especially if we're talking about elective surgeries like a joint repair, bariatric surgery. We have time to plan and we can replete people with vitamin D prior to prevent these complications. The biggest ones are wound healing and dehiscence, which is when the wound actually reopens after surgery, surgical site infection, recovery trajectory, so how quickly it takes them to get back up on their feet, rehabilitation capacity, how much time can they spend in physical therapy or physiotherapy, depending on what country you're in, the ability to spend sufficient time and effort in PT is a real big predictor of that recovery trajectory. So that's an important factor. And then overall resilience during recovery. So are we having these ups and downs? Are we able to bounce back from bad days? Vitamin D seems to be predictive of that. And overall, recovery is actually a process, right? It's not just any one thing. And the immune system, our metabolism, the endocrine system, tissue repair, inflammation resolution, all of those are important factors. And all of those are touched by vitamin D. So this is not simply about surgery as an event. Vitamin D status actually shapes the body's reaction to that event, right? The ability to overcome that acute injury. And inflammatory and immune stress, metabolic demand, tissue repair, and recovery are the three main components that are really driving that. Okay, vaccine responsiveness. So adaptive immunity is the ability of the body to learn how to react to something. And that's the whole premise behind vaccine. Is we give it an antigen, the body learns to react to it, and then when it sees the real thing in real life, it will react in a positive way. Now, if you don't have sufficient vitamin D status, that doesn't work so well. We don't see a great adaptive immune response. We don't see a sufficient antibody production or viral titer production after vaccination. So essentially not getting enough vitamin D and getting vaccinated is not getting the full dose of the vaccine in some ways. Then the immune response quality and coordination. So the ability of the immune system to kind of really learn that and then in follow-up to be able to actually swoop in and create that acute immune response that will hopefully rescue you from the pathogen, that can be affected with poor vitamin D status. So I just want to point out that I'm not saying this is necessarily a replacement for vaccination. Ideally, you'd be doing both. Having a strong immune system is always going to help prevent you, and then having your immune system learn how to protect itself with vaccines is also very important. But it is a modifiable factor, right? So we know vitamin D status is really important, and it's most relevant in groups that are aging, groups that have been hospitalized during that perioperative period, and chronic disease. So these are definitely groups that we should be looking at vitamin D status in, right? They should be generally screened. The broader implication is that vitamin D actually, right, it's effectively shaping the immune system and how it's responding. So to me, this really reinforces the value of this as a proactive status assessment, right? We don't want to reactively look at vitamin D. We want people to have sufficient vitamin D kind of just regular before they get sick. That's really the ideal way to treat this because you don't know when you're going to get in a car accident and end up in the hospital. So having sufficient vitamin D status will really help protect you in the long run. Okay, clinical implications. So from the literature, it seems quite clear we need to have this proactive assessment. We need to actually test what the vitamin D status is and not just make assumptions, right? Not just saying, oh, the dose in your multivitamin is enough, or on the flip side, saying you need 2 or 4,000 international units without actually testing, right? We need to know your number. Then we need to stratify by risk. We've identified many different factors that can really put you at risk for vitamin D deficiency: adiposity, aging, medications, and gut health. All of those things are things that we can measure or can really come to actually understand relatively easily. Then these approaches need to be individualized because we're starting at different baselines. You have the different absorption rates, different metabolism, different synthesis when you go outside. So you really need to know what that individual person's status is and how they're reacting to the supplement. And so because of that, we need to treat a target model, right? We're not just picking a dose and giving it to everyone, even if we know XYZ about them. It doesn't necessarily mean they're going to react like every other person that has XYZ category. So really looking at the serum levels as the driver. And I would use this as a parallel to acute care. So it's very common for someone to be admitted for acute care where we routinely optimize their fluids, their glucose, oxygenation, hemodynamics, all of these elements. And I would argue that nutrition and therefore immune readiness deserve the same consideration. So this would just be part of your checklist in acute care, making sure you have enough vitamin D status. And we did have some people talk about that earlier. So I was excited to see others thought so as well. So in my mind, the question is no longer whether variability exists, but how we incorporate variability into evidence-based, personalized, whole person care. So what does that mean? For me, it's really about timing. Timing is critical. A correction after the acute crisis is likely too late, even though it's something we can also do. I would prefer us to be actually being proactive. The timing helps explain why we see mixed findings in RCTs. A lot of times what we are having is an event and then we are treating vitamin D and seeing how the outcomes work. And my argument is that is too late. And while it's better than nothing, it is not the optimum way to handle this. So looking at status before the stress drivers is really what's going to drive recovery. And rescue dosing cannot simply reverse early dysregulation. It's the immune system takes a while to recover. And so having that rescue dosing, while beneficial, is likely insufficient in many cases. And so I would call for risk-based screening in public policy, really identifying those high-risk groups before surgery, illness, pregnancy. We're really kind of just generally knowing at-risk groups because anyone could get into a car accident and end up in acute care. So the focus on preventative public policy, moving from reactive treatment to proactive optimization across the life course. We talked a lot about how it's important in the maternal fetal transition. It's also important, in different parts of our life as we are growing bones and whatnot. So just kind of across the life course, we need to know that we're getting sufficient vitamin D. And then finally, at the population level, we need to have equity and address modifiable status risk factors, right? So we know certain groups are at higher risk than other groups, and it doesn't seem right to not treat those groups just because we're saying, oh, most people are probably okay. And I would argue that today, I think we've shown that most people are probably not okay because we spend too much time indoors. So in summary, please think about proactive optimization instead of post-crisis rescue and the opportunity to translate vitamin D into better public health. And with that, I will stop sharing.
Excellent presentation, Dr. Frame. Thank you. So next up, we have Dr. Richard Chang, who is an NIH-trained physician scientist and practicing clinician focusing on nutrition-based systems approaches to chronic disease. He has been developing an integrative framework referred to as IOM systems medicine that brings together orthomolecular, metabolic, and systems-based perspectives. He serves as editor-in-chief of the Orthomolecular Medicine News Service and as a board director of the Riordan Clinic, with his work centered on nutrient biology, chronic disease prevention, and systems level contributors to health and disease. Dr. Chang, are you ready?
Well, okay. Well, thank you, Jen, for the introduction. I would like to briefly discuss why clinical responses to vitamin D can vary so dramatically between individuals, and why a systems-oriented perspective may help explain these inconsistencies from a systems medicine perspective. Vitamin D should not be viewed as merely an isolated nutrient, but rather as part of a broader biological regulatory network. And for disclosure, I also serve as Chief Scientific Officer of DSORB, a nutrition company based in China. Well, most people have heard that vitamin D is important, yet clinical results are often inconsistent, as we discussed by many experts today. Some people respond dramatically, while others show little improvement despite supplementation. Some studies show remarkable benefits, while others show minimal or mixed effects. Public health officials and the public are understandably confused. But perhaps the issue is not vitamin D itself, but how we understand human biology or systems biology, as several experts alluded to today. Vitamin D is often discussed as if it affects only bones or calcium metabolism, but in reality, vitamin D influences multiple physiological systems simultaneously, including immunity, inflammation, metabolism, endothelial function, and mitochondrial activity, neuroendocrine signaling, and gene expression, as many, particularly Dr. Harlick in his first lecture, mentioned. So this may help explain why vitamin D deficiency has been associated with such a wide range of chronic diseases. Importantly, it also suggests that vitamin D should not be viewed as an isolated nutrient, but as part of a larger, broader biological regulatory network, as shown in this diagram. Now, this is important, I think. One missing concept, in my view, is biological barrier integrity. Vitamin D does not act on just one organ or on one disease. It helps support multiple biological barriers, including the gut barrier, as we know, lung barrier, vascular endothelium or vascular barrier, skin barrier, the eye, and even the blood-brain barrier. When these barriers become dysfunctional or leaky, the result may be chronic inflammation, increased infection, susceptibility, immune dysregulation, and greater vulnerability to chronic disease. This systems level perspective may help explain why vitamin D responses so dramatically between individuals. So this is what I call systems level, systemic leaky barrier syndrome framework. So this is a simplified illustration, as we are very familiar with in the leaky gut. So what we mean by biological barrier, healthy biological barriers are selective and protective. They help keep harmful substances out while allowing nutrient signals, normal immune communication to function properly. But when these barriers become inflamed or dysfunctional, they become more permeable. Sometimes we're referred to as leaky. This may allow toxins, pathogens, inflammatory triggers, and undigested particles to enter the bloodstream and activate chronic immune responses, as in the leaky gut. However, this doesn't happen to only leaky gut. We can have leaky blood-brain barrier, causing brain problems. Okay, so importantly, this concept is not limited to the gut. Similar barrier systems exist in the lungs, the vascular endothelium, skin, and the blood-brain barrier, as I just mentioned. From a systems medicine perspective, vitamin D may help support the integrity and the resilience of these biological barriers throughout the body, protecting us from various diseases. So two people may have the same vitamin D blood levels, yet experience very different biological responses. Why? Because vitamin D biology is highly individualized. Response may depend on inflammation, metabolic health, nutrient cofactors, different diets you eat, a lot of ultra-processed foods you eat, body composition, sleep, stress, genetics, and overall physiological resilience. Vitamin D does not function in isolation, which is critical. It functions within a complex biological system, and the systems oriented perspective may help explain why vitamin D studies often produce inconsistent clinical outcomes. As a clinician, this is particularly important. Clinicians should not treat a single symptom, a single issue, but a whole body. This concept may help explain why some individuals respond poorly to vitamin D despite apparently adequate blood levels, inflammation, metabolic dysfunction, oxidative stress, barrier impairment I just mentioned, and other chronic physiological disruptions may interfere with vitamin D signaling pathways and the receptor responsiveness. In this situation, the issue may not simply be vitamin D deficiency alone, but reduced biological responsiveness to vitamin D itself. From a systems medicine perspective, improving vitamin D function may therefore require restoring the broader physiological environment, not merely increasing supplementation. So traditional reductionist medicine often asks, as illustrated by some of the earlier speakers, Dr. Harlick, Dr. Grant, and Dr. Sunil, and a few others. So the traditional, like I mentioned, medicine asks which nutrient affects which disease, but systems medicine asks a different set of questions. What impairs resilience? What increases inflammatory burden? What weakens biological regulation? What disrupts metabolic flexibility? As several experts on today's panel emphasize, vitamin D should not be viewed as an isolated single nutrient. Its biological effects depend on a much larger physiological networking involve magnesium, vitamin K2, metabolic health, immune regulation, mitochondrial function, inflammation status, and the biological barrier integrity. From this perspective, vitamin D is less a standalone molecule and more of an integrated systems regulatory network. IOM systems medicine is one systems-oriented framework that attempts to integrate root drivers, biological mechanisms, and physiological resilience into a more unified understanding of health and disease. So from a public health perspective, this means we may need to think beyond isolated nutrient recommendations alone. Vitamin D likely works best within a healthier physiological environment, one that includes metabolic health, healthy diet, good sleep and circadian alignment, nutrition sufficiency, and lower inflammatory burden. Health is not linear. It emerges from the interaction of many interconnected biological and environmental factors, and this may be one reason why public health strategies focused on only one variable often produce inconsistent outcomes. So to summarize, first, vitamin D is a systems regulator, not just a nutrient. Second, biological context matters. Third, vitamin D resistance may be rare and clinically important. Fourth, supporting the broader physiological environment may improve vitamin D responsiveness. And finally, a systems-oriented approach may help improve long-term public health outcomes. Final message, the future of public health may depend less on isolated interventions and more on restoring human biological resilience. This is the central philosophy of integrative orthomolecular medicine, systems medicine. Orthomolecular medicine, pioneered by Linus Pauling and colleagues over 50 years ago, helped establish the principle that the body's nutritional and molecular environment profoundly influences health and disease. Today, integrative orthomolecular systems medicine expands upon this foundation by integrating nutrient sufficiency with metabolism, biological barriers, inflammation, endocrine regulation, and systems resilience. The Awesome Molecular Medicine News Service, or OMNS, has served this field for 2 decades as an independent educational platform dedicated to science-based nutritional and systems-oriented medicine. If interested, please feel free to scan the code to subscribe to OMNS Interactive. Thank you very much, Jen. Over.
Thank you very much, Dr. Chang. Okay, we have our last speaker, and then I will close, and we will go into open Q&A. So hopefully you guys can all stick with us a little bit longer. I apologize for going over time. So I would love to introduce Dr. Beth Sanford, who earned her BSN and MSN in rural health nursing with a specialization in nursing education from the University of North Dakota and completed her DNP in public health and policy. Dr. Sanford later earned a postgraduate certificate in applied clinical nutrition to close the research practice gap to address vitamin D deficiency in patients and populations. Dr. Sanford is a full-time graduate nursing educator and is a director of education and clinical practice for Grassroots Health. She is the current president at the North Dakota Nurses Association and the North Dakota Center for Nursing, and she advocates for nurses and nursing students across the state and nation. Welcome, Beth.
Thank you, everyone. I have really enjoyed listening to all the presentations of my distinguished colleagues, and I wish I had time to edit every slide in my presentation just to reiterate the wonderful things that I've heard today. I'm going to be closing talking about the implementation of vitamin D science into policy, population health, and practice. So we could see from all the presentations today, vitamin D science has grown significantly in the last decades. Vitamin D is crucial for genetic and cellular optimization. Current one-size-fits-all dosing recommendations are not effective to achieve optimal 25-OHD serum concentrations and improve patient outcomes and population health. Vitamin D optimization is a modifiable risk factor in preventing health disparities. And evidence suggests that 25-OHD optimization thresholds are body system specific, ranging anywhere from 30 to 80 nanograms per milliliter, even higher for special conditions. As I continue in my career to review the vitamin D science, it's clear to me that we lack a framework that organizes risk in a way that patients and populations actually experience it. And optimization best practices in a clear way for decision makers so that they can make the best decisions possible to support our population health and our clinical practices. So I'd like to introduce something that's a work in progress that I'm calling the vitamin D risk ecology. And it's a framework that I developed to help understand and anticipate vitamin D risk and optimization of best practices. On this first slide, I'd like to address the 3 domains at the top of the model, looking at environmental context, population health, population vulnerability, and individual risk profile. These domains remind us that the risk is partially shaped by where people live, by where we work, by most of us within the same geographic area for most of our life. The next area of population vulnerability reminds us that some groups may benefit from earlier intervention and targeted prevention strategies, like I've heard from my colleagues today, looking at pregnant women, those with darker skin tones, occupational risk, including college students who I work with, and finally, that 2 individuals may live in the same city, eat similar diets, receive similar supplementation recommendations, but their biological response may differ substantially. These 3 domains make up the ecology of the vitamin D risk, vitamin D deficiency risk. And next, I will address just reminding us of some symptoms of vitamin D deficiency. So there's some common symptoms. This isn't reflective of all the symptoms of vitamin D deficiency by any means, but it is a fairly significant list, and it's important for patient follow-up and also important for insurance coding. I think probably the number one comment I get from clinicians is, well, vitamin D testing is not covered by insurance. Actually, it is, depending on how we document. So documentation and coding for insurance purposes is very important. So these are some of the symptoms that can clue a clinician that their patient may be vitamin D deficient. Fatigue, generalized weakness, sleep disturbance, cognitive impairment, such as impaired focus and memory, headaches, mood imbalance, for example, depression, anxiety, poor stress management, neuromuscular pain, post-surgical pain, frequent infections, including hospital-acquired infections and post-surgical infections. As I said, and I can't emphasize this enough, these need to be specifically documented in the patient's record and need to be followed up on. And this is so important for insurance coding because with these symptoms, you can justify presumed vitamin D deficiency. Now, let's go back to our optimization continuum and we'll look at what the next steps are. So this portion of the model is actually adapted from a 2022 cycle of best practices for addressing vitamin D deficiency that was developed by Grassroots Health Executive Director Jen Aliano and myself. After assessing risk in our patients, which includes that environmental context, population vulnerability, and individual risk, and identification of symptoms, then we would look at either coding as screening or testing for our patients, testing that 25-OHD. And then once we get that result, we can look at calculating that individualized dose. Now, this is where Grassroots Health has really done some great work, is that they've developed evidence-based calculators where you can input your patient's weight, current serum concentration, you can come up with a personalized dosage recommendation. The clinicians that I've worked with that have implemented the use of this calculator have just said that it's taken so much stress off their shoulders. It's just a really quick e-tool that they can input that information in and they can have a recommended loading and maintenance dose so that they can not only achieve, but like our presenter said, but sustain and maintain that serum concentration for maximum optimization for their patients. And then the next step, of course, is to educate our patients. We want to empower them with that knowledge to address those modifiable risk factors. And with what are practical strategies that they can do to optimize their sun exposure and optimize their vitamin D with use in nutrition. Maybe their magnesium is not sufficient, things like that. So how can we individually educate our patients for maximum optimization? And then in addition, it is our responsibility as that clinical team to help the patients with follow-up and to monitor that status so that it stays in consistently in that optimized fashion. I know, for example, if somebody has something come up, it can change what their needs are. For example, I had my mom so that she was consistently hovering around 60 nanograms per mil. And she only had to be tested a couple of times and we knew, okay, this is the dose that keeps her about 60. Now, she unfortunately got an infection from a tooth procedure because she didn't take her antibiotic like was prescribed, and she ended up with sepsis. We had just had her vitamin D tested, and within 30 days, she rapidly was depleted from 60 to 30. So it shows how quickly under pressure, under stress, the body will utilize that vitamin D. And thankfully, because of one of Dr. Wim Lewance's articles, I was able to see that in action, that my mom's vitamin D was over 60. She had a 97% chance of surviving sepsis, and she did. So that's my personal recent great story about vitamin D. But in general, we want to dose and monitor and follow up for that general recommendation, like our panel said, between that 40 and 80 nanograms per mil, based on the patient's specific risk, history, and health concerns. I always tell my friends, if you have a family history of breast cancer, you don't want to be hovering around the low end, right? We want to see what the research says, and the research says if you have a family history of cancer, you want to be higher than that. And so just remember, normal range is considered 30 to 100 nanograms per mil, and that's with several of our big laboratories saying that these are normal. And I want to make a note that these best practices are really for high resource countries and regions. Obviously, this isn't practical across the globe, but we're not covering that in this presentation today. And that's something I cover in some of my other work that I've done. But this is very practical in high resource regions and countries. So lastly, I want to move back to the anticipated outcome section of the diagram that's to the right of the arrow. And if we follow this model and we look at precision public health, which identifies environmental risk, population vulnerabilities, it allows regions and communities to implement targeted prevention strategies that will strengthen their overall specific health. And that's going to look very different. And if you live in the northwest part of the United States, for example, where you have a lot of cloud cover and a lot of rain, compared to if you're in the southwest, where it's very high heat, but people may be causing their own vitamin D winter by going indoors. So just to give you a few examples, I live in the northern plains where it's so cold all the time. We don't even get UVB rays hitting the earth for 6 months of the year. So we have a very different strategy than our colleagues in the south of how we need to keep our population's vitamin D serum concentrations high. And so it's each different region of the US that precision public health should be informing precision medicine how to improve their patient outcomes. And then they can take that public health information and move that into individualized care and use targeted interventions to decrease the modifiable risk of that particular patient. These things working together then do help preserve healthcare resources, reduce waste, reduce medical spending, because there are fewer complications in our patients. And we have a stronger workforce and more sustainable healthcare systems. And just remember, vitamin D risk becomes more predictable when you look at the environmental context, population vulnerability, and individual risk profile, and when they are considered collectively. Now, how do we rapidly improve global vitamin D status? I just want to move to the globe just for a minute here. And if we look at this diagram, you can see this is a modified socio-ecological model that's surrounded by environmental and cultural context of the community that it's serving. So we'll move from healthcare policy to looking at population systems, the community, and institutional perspectives down to interpersonal and where that clinician relationship really sits, and then individual levels. So rapid optimization of global vitamin D status can be accomplished very quickly and safely through multi-pronged precision public health and precision medicine approaches that would target every level of this socio-ecological model. This model is very practical. It helps us to understand how to design interventions that can impact multiple levels at one time, saving money. And it's really, for example, it can be used in an updated national policy, which is the purpose of this panel and what we are hoping for, can be used to trickle down and inform every level of this model. And it can be used as a foundation for public health initiatives. We don't need separate necessarily public health initiatives, but we can incorporate vitamin D science into every other public health initiative that we are really doing. Because vitamin D, like Dr. Grant said, impacts 8 out of 10 of the leading causes of death in the United States. We can use it to inform community health programming, workforce health initiatives, practice protocols, patient education, and inspire people like us for individual health decisions. So my final recommendations for today, for policy, we definitely need to update guidelines to regionally specific sun exposure and vitamin D dosing recommendations and enact state-specific concurrent resolutions like Alaska and North Dakota have done that are related to their environmental health and population risk factors. It should be added to workforce and military health initiatives, specifically for cognitive, mental health, physical health initiatives to address stress and burnout in our workforce and in health as well. And like I said, added to specific public health initiatives like WIC, like cancer prevention programs targeting women's health and breast cancer, can be easily integrated into those programs very cheaply and affordably. For research and quality improvement, I think my colleagues covered this really well. Standardized research design per the Haney criteria is really important. And if we had some homogeneity in our research design, it would really make the outcomes much easier for us to discuss in the literature. From education, we need to increase access to vitamin D knowledge. For example, physiology, consequences of deficiency, risk, symptoms, research design, and practice protocols for all decision makers and healthcare professionals in training programs and through continuing education. Now, practice, we need to look at increasing, assessing patients, screening, testing, and repletion and maintenance of every patient's 25-OHD status to that minimum target of 40, which really, like Dr. Wimelon said, is really pretty low. And using grassroots health calculator and e-tool protocol, we can improve patient outcomes and preserve those healthcare resources. I'm taking note to that BMI sensitive dosing to the target. In my personal opinion, lack of education is the biggest barrier that we have to change this. That's why we're doing this webinar today. This is why we all work so hard to write and publish articles and do presentations. None of us are sitting around idle. Right beside me, I have two large textbooks. These are volumes 1 and 2, and there are a lot of contributors on this panel to these large textbooks. And if you are concerned that maybe there isn't enough vitamin D science, I encourage you to buy these and read them. I tell you what, there's so much information there. I really now carry them around to every presentation that I do so that people get it. The science is there, it just needs to be translated into practice. One of the other things that I'd like to just make a comment about is about barriers to successful projects, because I personally have struggled with this in the vitamin D projects that I've done. We need to educate the people that are involved with our research and with our quality improvement projects. We need to share the research studies. I'm not kidding you. I drown people in research studies. You got a question, boom, here's a study. Boom, here's a study. Boom, here's a study. And a lot of people on this panel, I've emailed and said, hey, you got a study on this one? Because I got somebody who needs to hear it. And I don't want to spend the time in PubMed, but I know that everybody has to at the tip of their fingers, right? Drown people in research because the research is there. People just need to read it and get it in their hands. Probably the top tip I have is to test the key stakeholders' vitamin D concentrations because most of them are in the toilet. Then they really do see, oh, wait a minute, my personal level is bad. Maybe this is a priority. Negotiate the cost of the vitamin D test in any studies that you do. In several projects I worked at, a facility came back with, we had this price, ABC price for each of the testing. Now, I happen to know that the actual cost of vitamin D testing is very, very low. Like the military cost for a vitamin D test is like $4 something, right? So we don't need to be charging $300 a test, $600 a test. We don't even need to be charging $50 a test. But I've successfully negotiated the cost of 25-OHD tests for some of my projects. So negotiate. Follow up on your project people and progress frequently. I had one project, to be honest, that I kind of dropped the ball a little bit and didn't follow up. And I went back and followed up and found out that they had a new staff member who had quit doing vitamin D tests on all their brand new inpatients. Well, that really threw a nice wrench in my project. So thankfully, I have a couple years of data before that, but we actually had to stop the study because we had a new person who stopped doing testing upon admission at the facility. So again, if I didn't say it enough, when you've educated, come back and educate again, because that is really the key to a successful research and work project. That is all I have for you today. I want to hand it over back to my executive director, Jennifer Aliano. Thank you, everyone, and thank you for your time here today.
Thank you, Beth. And I do want to thank everybody else. Beth, I'm glad you brought up your concurrent resolution. Alaska and North Dakota are the only two states that have a vitamin D resolution, and I challenge anybody on this call or anybody who watches it to champion their own state's vitamin D resolution. And if you have questions about that, just reach out to us at Grassroots Health. And I also want to just update everybody on a couple things coming up. Grassroots Health is in the process of building an online vitamin D consortium where we can all gather and we can all advocate together. We're going to have frameworks to share where anybody can participate from the individual level up to the policy level to really implement this research into practice at all levels. And so I'm going to just share a few closing slides to tie this all together and to give everybody some take-home actions. And before I do read through these, I want to really emphasize an important point. We know that vitamin D is only one piece of the puzzle, and we know that our diet, that our environment, pollution are also very important. But please remember, vitamin D is an incredibly easy, safe, inexpensive way to really improve health. It's the lowest hanging fruit, in my opinion. And that's why we are focusing on vitamin D, and everything else hopefully will follow. So, vitamin D deficiency and insufficiency are common, yet easily preventable and harmful, and can result in long-term health consequences well beyond bone health. Health policy and nutrition guidelines should be updated to reflect the current evidence. Based on this knowledge, we suggest the following changes, and I'm not going to read through all of these because they've already been reiterated by many of our presenters today. But number one, the minimal 25 OH vitamin D sufficiency range of 40 to 60 with upper normal optimal ranges up to 80 or even 100 nanograms per milliliter should be set. Higher serum concentrations may be necessary for specific conditions and individuals. 10,000 IU per day should be set as the safe upper limit, as it was through the Endocrine Society previously, instead of 4,000 IU per day. I can't tell you how many people I've heard online. They give amazing presentations about vitamin D, but where they really fall short is they say don't take more than 4,000 IU per day. Because that is the safe upper limit, and anything above that could be toxic. And that is just such bad misinformation that is contributing to the harm and the confusion surrounding vitamin D. Calculating doses based on weight or BMI, we've gone through that many times. The dose to target protocol of testing and retesting to ensure that a target level has been achieved. And then also different protocols for hospitalization, and that are included here. In addition, medical education, education in general is of utmost importance. Grassroots Health just had our online vitamin D education course, which is built for practitioners to help move vitamin D research into practice, but it's really anybody can take it. It was just approved for 11 CEs, continuing education units for nurses. So I really hope that you'll go to our website and check that out, share it. And then also, addressing all the places of misinformation or shortcomings when it comes to vitamin D on all government websites is important, an important next step. And we covered a little bit about insurance, but there's other things that are really acting as barriers to implementing the research into daily practice that need to be addressed. Optimizing vitamin D status proactively is an important clinical and public health consideration that must be acted upon now, especially recognizing pregnancy and early infancy as periods of heightened vulnerability to vitamin D insufficiency. And this is what I want to close on, because we're affecting the lifetime of our infants. And really, when it comes down to it, that preconception phase is when vitamin D deficiency and insufficiency really need to be addressed. So, and this is something that came from Dr. Wagner that I wanted to close with. Unlike many other stages of life, pregnancy and lactation involve dynamic maternal, fetal, and maternal infant interactions in which maternal vitamin D status directly impacts the developing fetus and infant. These early life developmental periods may represent some of the greatest opportunities for long-term health impact through prevention and optimization of vitamin D status. This has important implications for clinical guidance, preventative care, and public health policy. And with that, I thank everybody. Please feel free to email me, jen@grassrootshealth.org, if you have any questions, especially if you have questions that we didn't get to today, because I know that we are out of time. But we will open up for discussions now for our Q&A, and I'm going to hand it back over to you, James.
Thank you, Jen. That was amazing. I learned so much. So I just want to pick up on the thread for a minute. There's actually, it's little known fact that aluminum hydroxide causes phosphodemia. And the initial use of aluminum hydroxide in medicine led to a condition that was actually misdiagnosed as rickets. So there's your vitamin D connection. I will actually be publishing an article on how aluminum hydroxide can cause vitamin D deficiency. The mechanisms are very, very clear. And so this is a fantastic panel, and it's great what you're doing. I'm a huge supporter, and I want to be sure that you guys get as much material in front of HHS as possible. The pathways towards research funding, the pathways towards center grants, and all of that. I'm very familiar with all of that. In the groups that you're talking about, the consortia and all the rest, I've already offered to open up spaces on the new IPAC EDU forum. They're private. You can do file sharing. It's all your material, and I own it, so it's not like anybody's going to steal your information. So what I'd like to start with is, Jen, we've come so far in the knowledge base, and repeatedly everybody is repeating, we don't want to do randomized clinical trials. And yet the clinicians that become regulators, it's beaten into their heads, randomized clinical trials is the gold standard, you have to have it. What's the plan to convince them that the consilience of evidence from mechanism of action, from improvement of health after the intervention of vitamin D supplementation, of testing people who need it and seeing that their health improves, from testing people who don't need it and their health doesn't improve anymore, that consilience of evidence itself, what's the plan and the pathway to have this regulated in a way where insurance can actually give sufficient coverage, not just for testing, but also potentially for prescription?
This is the plan, James. We're presenting the evidence right now and not just focusing on randomized controlled trials, which, when designed properly, I think just like Dr. Weiss and Dr. Mirzakhani really pointed out in detail when it comes to pregnancy, when these randomized controlled trials are designed around nutrients with specific criteria in place, and we are enrolling people who are coming in with a baseline deficiency and treating to a sufficient level, and really monitoring that level throughout the study.
What is the income for grass?
Oh, then we'll be able to see more reliable findings. And so, but the education piece is what comes first. And when you talk about insurance as well, that's where we're asking for help, right? That's where we're asking for our new connections, or what is it we have to do? We've got the scientists, we've got the experts. They have the knowledge. What more do they need to ensure universal coverage of vitamin D testing, of the education? How can we implement vitamin D protocols into prenatal standard of care or WIC programs, and other things like that?
Yeah, for sure. So the other thing I wanted to say just before we get to some of the questions, which I pulled aside for you, I really appreciate Dr. Human's caution about hedging on causality. But clinical science, nutrition science, so many of us have been socialized to do that, to hedge on causality, especially when we're speaking in public. But there are things that we know, right? There are things that we know about vitamin D supplementation. We have things that we know based on the again the consilience of the evidence, which comes from E.O. Wilson, the evolutionary biologist, that if there was a way to express policy, and I want to congratulate Beth on her fantastic presentation on policy recap, and Jen and your contribution to those ideas and everyone's, but if there was one policy that HHS could implement right now, what would it be?
I mean, this is my personal opinion, and I encourage anybody else to chime in. But I really think it needs to be if we don't change the government recommended guidelines, people are always going to fall back on them as their excuse, no matter what education they receive. I think that needs to be the number one item that we address.
We're close. We're pretty close to that. So fingers crossed. Okay, so Ed Kellogg has a good question here. If everyone in the United States simply had a year-round sufficiency of vitamin D, what kind of impact, as a negative percentage, do you believe that it would have in the overall revenue of the medical industry?
I believe that question was aimed at Dr. Grant.
Yeah. Dr. Grant, you want to weigh in? I have to ask him to.
Okay. Well, I don't have an exact answer, but I do know I've done studies from various countries like Canada on the effect and Europe. I'd have to go into it, but I'd imagine if you're going to have 20 to 30% reduction in mortality rate, you from raising vitamin D, you might have a 20, 30% reduction on the costs. However, there are, of course, fixed costs because the medical system wants you to come in for exams and this procedure and that procedure and so on. So it'd be difficult. So this could be a something that might upset the medical system. And the medical system hires what 20% of the population. So it could be it'd be widely fought by the system.
Yeah, well, thank you, Dr. Grant. There's no doubt about that. We do have an overbuilt medical system that's reliant on sick people. Another question I thought was fascinating, came right out of the gate when we were discussing genetics, comes from Kristen B's VDR polymorphism question. Does anyone plan to look into this future to determine why certain genotypes are non-responders?
I think Dr. Mirzakhani or Dr. Weiss might, or any of you on the panel, you are more than welcome to step up here.
I just have a quick comment on this. I read a study, and maybe this will trigger someone else's mind, that prenatal vitamin D exposure impacts the development of those VDR receptors. And so that if a mother has really low vitamin D serum concentrations, the infant won't even develop VDR receptors. Is that true? Maybe if Dr. Hollis or Mirzakhani or Weiss is, maybe they can address that. I think that would maybe have some response, would have some connection to adult response to vitamin D serum concentrations.
A fascinating possibility. I'm not sure that it's been studied. So, but Beth,
may I make a comment here?
Yeah.
Yeah, actually, I believe, well, I have a PhD in genetic molecular biology, but I think the genetic component has been overemphasized. And I made a study, and I found 10 categories of rule drivers. And I believe lifestyles, particularly dietary factors, play a lot more important roles in these issues than the genetics, particularly like the asthma and autism mentioned today. You can't simply use genetics to explain. For example, cancer. Over the last 30 years, cancer rate in the young people under 50 has increased by 80%. It has nothing to do with genetics. Autism, the same thing, has increased so much, has nothing to do with genetics. So yes, genetics does play a role, but it's at the bottom of my list.
Okay, well, thank you for that, Dr. Cheng. And thank you, Beth, for that. Fascinating. I was going to say that there are some examples where environmental exposure, say for endocannabinoids, if you have too few of them, you don't have enough receptors. And so low dose endocannabinoids can cause an increase in receptors. So there's precedent for that. So yeah. Fascinating stuff. Another good question. Richard Smith Jr. says, why not have recommendations for dosing that would be based on international units per kilogram body weight per day? Which is what, ironically, I criticize FDA of not doing when it came to aluminum hydroxide and vaccines in the pediatric schedule. They would just say, oh, 800 micrograms. So, yeah, what are your thoughts on that? Anyone?
I think Dr. Hollick should address this because he has the most experience with interacting with those panels.
Okay, Dr. Hollick.
Yeah. So why don't you repeat the question?
Yeah. So the question is the expression of dosing. You have international units as a base
Yes.
range. Why not express it in this probably comes from environmental toxicology thinking. International kilograms dosing question, sorry, international units kilogram dosing might actually be expressed as international units kilograms body weight per day. So based on body weight as a
So yeah, so it turns out that what's curious is that, even though there are these calculations out there, what is true is that you can have a 1-year-old getting 600 units a day, and you can have a 10-year-old get 600 units a day, and the blood level will be the same, and the body weight is a lot different, right? You have at least three different 25 hydroxylases. And one of the observations that I think we've all made is that if your blood level is around 5, even if you take just a couple hundred units of vitamin D, one of the hydroxylases, the Km is such that it rapidly converts as much as it can to 25-hydroxy-D. And so as a result, the 25-hydroxy-D will rise very rapidly to about 15 to 20 nanograms per ml. And then for every 100 units, it only raises by about 0.6 to 1 a nanogram per ml. So it's nice to see for obesity, for chronic illnesses, including inflammation, you probably need more vitamin D. But for the most part, the body has been pretty good at being able to regulate the level. I saw in one question that one person said that my level's a lot higher than I would have expected. It turns out that the 24 hydroxylase, right, is the major contributor for your 25-hydroxy D. And there's a significant number of people out there that have a partial 24 hydroxylase deficiency. And as a result, the dose of vitamin D that they take, their 20-hydroxy D is higher because it's not degraded as fast.
Yeah.
I
Well,
did see
listen,
Robin Whittle raised her hand as well to address this question. Thank you, Dr. Hollick, by the way. Are we able to unmute Robin?
I think so. Let's
Okay.
find her.
It's nice to see your face, Robin. I've been on many threads with your name on it.
There you go.
Okay, here we go. Test 1, 2, 3. Hi there. I'd like to thank everybody, and also I just want to say hello to Reinhold Veith, who wrote in 2004 that vitamin D is not a hormone, and that we need to talk about the 3 compounds as separate compounds because they have different functions in the body. I just want to totally support that. I want to speak about the value of Sunil's recommendations for supplemental vitamin D quantities as ratios of body weight. His is the only peer-reviewed journal recommendations along these lines. He has, is one of his slides, he recommends a certain amount of IUs per kilogram, a range of IUs per kilogram for ordinary weight people and people who are overweight and underweight. But for obesity 1 and 2, he has a higher range, and for obesity 3, he has another range. Now, I believe that those recommendations are ideal, and that's what should be the national policy because it suits everybody. It doesn't depend on race, doesn't depend on body weight. It just handles all that sort of thing, and it doesn't require any further research because it will and the target is to achieve at least 50 nanograms per milliliter circulating 25-hydroxyvitamin D, which is a really great target. This idea of aiming for 20 or 30 is just obviously wrong. You can look at research and see that the immune system dysfunction starts at 50, and anything below 50, you get more and more post-operative infections. So 50 is a really good target, 50 or higher, and the recommendation should be Sunils. I can't think of anything better. The alternative is to try and modify the RDA, and this is absolutely not the way to go. The RDA is just a broken concept because it doesn't take into account body weight. If you had a target of 50 nanograms per milliliter, 25-hydroxyvitamin D, I did some rough calculations last night, and I wrote it in a comment a few hours ago to your most recent, James, your most recent Substack article. I looked at the statistics for the United States population. Because all the nutrients depend on body weight, the amount you've got to give them to achieve sufficiency. But in the case of 25-hydroxyvitamin D, it's made even worse by obesity, because obesity reduces the ability of the liver to hydroxylate vitamin D3 into 25-hydroxyvitamin D, and also the excess adipose tissue seems to absorb the 25-hydroxyvitamin D and not give it back. So you really need to have the high ratios that Sunil has with obesity. But anyway, if you want to do an RDA for 50 nanograms per milliliter 25-hydroxyvitamin D, one way to do it is to find who are the people in the United States population who are at within the top 2.5% of the body weight, because they're all suffering from obesity 3. And I try to calculate what that threshold is. What is the body weight? And I came up with 133 kilos, which is 290 pounds. And reversing Sunil's recommendation for obesity 3, I estimated that the RDA to get those people up to 50 nanograms is about 18,000 IU a day. Now, that is ridiculous to recommend to the population, because the RDA depends entirely on those top 2.5% of the body weight. So the RDA is not the way to go.
I have to say, Ron,
I could talk
agree
more.
completely.
That's what I want to say.
The physiological dynamics of uptake, metabolism, and clearance of vitamin D in all of its forms will be different based on all of those physiologic factors that you mentioned. And that's why I like, Grassroots Health's message. You need to test to know where you are. You need to test. It's not superfluous to test. If you are a person that suffers from chronic illness and you say, oh, well, I'm just going to up my vitamin D, you're shooting in the dark. It really depends on all of these other factors. So your message is really hitting home. But one of the things you can do is you can ask your doctor, hey, I'm curious about my vitamin D level. Do you know what it is? Oh, I don't know what it is. Well, let's test it. Okay. And if they don't know how to get through the paperwork for that, have them contact, or better yet, join Grassroots Health, because send them this video, because the education that's here is, and attend their education for continuing education credits is just so fundamentally important. One of the policy changes that came up in question was, hey, we have to teach nurses, we have to change medical education and all the rest. I put out on Twitter today, I think the medicine has to stop treating the average patient. They have to stop thinking that the next patient that walks through the door is like the last 6 that they saw. And the individualized medicine approach has benefits for the doctors as well, because they have more to do with maybe fewer patients, but they'll have more to do. And nobody's ever done the economics of the trade-off of actually taking into attendance. When I started doing cancer research, when I found out that vitamin D was a risk factor, like Keith Baggerly really emphasized for cancer, that's what it really got my attention. But what I've learned since is the profound effect that it has on so many conditions and so much of the human health and the chronic illness that we see. It's a quick win to do something about increasing the general population's dose. And I think, everything simplifies when you do HHS math, right? They have to have an RDA, right? But what is an RDA unless you consider these other factors is very good. So
You should
RDA
consider
with
vitamin
testing.
D as a prevention, right? Not to be intervening just when you have a chronic illness. That
Absolutely.
should be the message.
That's the thing, right? How do you stay healthy? If we transitioned our mental mindset from getting better when you're sick to staying healthy across the United States and across all around the world, and you saw your doctor as a partner in maintaining your health and getting healthy and staying healthy, then you empower the patient. There's a little bit of a language war going on in medicine. I don't know if you've noticed, but there's no such thing as insulin resistance. I mean, there is. You can say the body is resistant, but from the person's perspective in their day-to-day existence, it's really insulin dependence. But doctors don't want to say you're dependent on insulin because we're Americans and we're strong and we're robust and we don't want to be dependent on anything, right? Because then that will light a fire to say, I don't want to be dependent on that. I want to do something. No, 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 just take your insulin, you'll be fine, is one message. Well, we're certainly not saying take your vitamin D and you'll be fine. We're saying you don't have enough of something that's fundamentally, profoundly important to your biology, and that's a different message. So, yeah. Well, Robin, I'll let you have a close-up thought there.
Great, thanks. Sunil's recommendations are intended for everyone, and it's not a medical matter. It's a nutrition matter because the natural source of vitamin D is ultraviolet B, which raises the risk of skin cancer, and it's not really available to most people. So his recommendations don't preclude the idea of testing vitamin D, and certainly anyone who's got any particular illness or is having consulting with doctors, absolutely, in Western countries, should have the 25-hydroxy vitamin D tested. But the value of Sunil's recommendations is that they will safely achieve at least 50 nanograms per milliliter 25-hydroxy vitamin D after a few months, all year round, for the whole lifetime, without the need for blood tests or medical intervention. It's just a matter of getting your body weight, estimating your obesity status, and any child can calculate it, and away you go. And it's applicable to everyone in the world, and it doesn't involve tests and so on.
I
So
totally appreciate that. And I think
that's the way to go.
I think you're exactly right. But here's
Yeah.
one thing that I've learned. If we
I
do
just
not
want to,
incentivize, hang on 1 minute, if we do not incentivize doctors to behave differently with money, they won't behave differently, right? So if they tested each of their patients in their practice for vitamin D, who they suspected might be deficient, they then have some skin in the game. And I'm sorry, it's an economic argument. It's not a scientific or a medical one. It's because they hold the authority of parents, especially new parents with their infants. Show me what to do because I've never done this before, and I'm not getting along with my parents anyway, so I'm entirely dependent on my doctor. If the doctor said, your kid is constantly sick. Well, I wonder what their vitamin D levels are. It gives the patient a data point to
oh,
remember.
sure.
Yeah,
Yeah.
it gives the patient a data point to remember to supplement. So there's benefits to testing beyond just knowing that you should do that,
Oh, yeah.
right?
Look, if you're seeing a doctor, you should absolutely get things tested. But Sunil's recommendations, if it are adopted by women of childbearing age, would pretty much eliminate or greatly reduce preterm birth, preeclampsia, mental retardation, and on it goes, But the final thing I want to say is that our responsibility as vitamin D experts, um, I'm not a researcher, but I will be one day. Our responsibility is to the people, and we somehow have to get to the people through the HHS and so on. And if they're doing something wrong, like thinking in terms of RDAs, we need to say so. RDAs are a moribund approach, and Sunil's recommendations are the way to go, and I totally support them.
Thank you. I'll take that seriously, and I'll bring that up with Secretary Kennedy because there's another factor that has to be considered just to throwing a number out there on the web. I'm just trying to stop them from distributing the wrong number.
Sure, yeah.
So let's have that conversation. I thank you very much, Robin, and
Thank you.
everyone else. So listen, guys, this has been great. The video will be distributed to everybody who registered as a free video to share. Please do share the video. And Jen, I'm going to make sure that this gets a wide distribution and an audience with some people that we hope will watch. They won't watch the whole thing, but I'll try to pull out parts of it that I think are very important. Could I ask everyone, make this into a working group, final thing, could you send me your slides? If you send me your slides, I can make them available. And maybe you'll see them in an HHS presentation. Maybe it'll result in an invitation to you to come to the HHS. We still want to have that live work group. And some final good news is I have it on very good authority that the vitamin D project to stop lying to the public about vitamin D dosing was taken out of the hands of the guy who decided that it wasn't an important thing. And that project is going to the hands of someone who does think it's an important thing. So I'm going to hold my friends accountable at HHS to come through for the people, Robin. We do owe it to the people and to each other. Jen, I'm going to let you close out to your audience, but please, I want to pitch to ipac-edu.org for courses and ipac-edu.online for a new social media experiment. It's just for people just like you from all different walks of health concerns and integrative medicine and so on. IRB members will be there, editorial board members will be there from my journal. I'm bringing all of my community together into one social media experiment that will feel very familiar. But please, I developed it, so it's going to be slow. Just give me some time to work out some of the bugs. Okay. So thanks, Jen. I'll let you close out.
Actually, I would like to give all of our panelists a opportunity with any of their closing remarks or any last things that you would like to say.
So I'm going to say, have a delightful day.
You too, Dr. Holland.
And go outside.
Yes.
All right.
All right, guys. Thanks so much.
That's it. I very much appreciate all of you, your life's work, some of you, and for continuing to stay in the game, as challenging as it's been for, I know I've heard stories that I appreciate the disinformation playbook, Dr. Grant. During COVID, was witness to several attacks against vitamin D, even just as minimal as sharing a paper in a social media platform, and just the attack that we received in return. So I appreciate all of you, your life's work, the energy that you put into this, and the passion that you continue to show. And thank you for being a part of Grassroots Health. And hopefully we can make some forward movement, not just baby steps, but really big strides and leaps with joining new forces, such as with you, James, and HHS. So again, thank you, everybody.
Thank you.
Thanks, guys.
Bye.